So, a very good morning to all. So, on behalf of Department of Ophthalmology, GMCH Chandigarh, I welcome you all to today's postgraduate teaching program. I also extend my warm welcome to all senior faculty members from Advanced Eye Center and my colleagues at GMCH Chandigarh. As you are all aware that we are meeting after quite a long time due to COVID pandemic. Around a year ago in December 2020, we met in the same hall. And during last 1.5 years, the mode of teaching has become online mode, which is I don't feel which is ideal way of teaching. And as the COVID cases are declining, fortunately, and I hope to see you more often, and I hope that more and more such programs are organized. And in today's program, we got registrations from Rishikesh AIIMS, from Srinagar, from Tanda Medical College, and from Dehradun. So I think they are participating for the first time, and it's good that our program is expanding. And the highlight of today's program is wet labs, especially DSEC, which is being organized for the first time at GMCH, and cadaver DCR. And with top of the line faculty and their guidance, I hope that all the participants, they have wonderful learning experience today. So in the end, I express my deep gratitude to all the senior faculty, especially Professor M.R. Dogra and Professor Arun Jain from PGI for sparing their invaluable time and being part of this teaching program. And I am also grateful to all head of departments of various institutes who have encouraged and motivated their residents to participate in this event. I am also thankful to all the residents who have come from far off places to become part of this program. And last but not the least, I am thankful to the industry partners, especially Novartis, Biomedics, and BIL for sponsoring this event. So, starting with today's program, I request Professor Sushmita to start first session, that is glaucoma goals. So, Dr. Srishti and Dr. Faisal, kindly start the first session. Thank you very much.
Good morning and welcome. It's a pleasure to be here, and I thank Professor Suresh for organizing this every time. And actually, it's probably our first physical meeting after a very, very long time. So we start with the glaucoma session, and it's my pleasure to invite Dr. Faisal. Dr. Faisal is Associate Professor with us in PGI, and he would be talking upon disinfection and evaluation of tonometers.
Very good morning, everybody. Thank you, ma'am, and thank you, Professor Suresh, for giving an opportunity. So I will be discussing about tonometers, evaluation, and sterilization. The key points involved for the talk is importance of tonometry, a little bit about the IOP, various techniques of various type of tonometers, sterilization, and calibrations. So why there is importance of IOP? As we know, the glaucoma is considered to be the second leading cause of blindness worldwide. Around 60 million people have been diagnosed as glaucoma worldwide. And the most common risk factor is increased IOP. So assessing the specific changes in IOP over time is essential to diagnose and treating the glaucoma. We know we need some kind of pressure to maintain the normal integrity of the eyeball. The intraocular pressure is the fluid pressure exerted by various fluids within the eye. So it is determined by the aqueous production and its drainage. So what is normal IOP? Normal IOP for 95% of population is 10 to 21 millimeter of mercury. For the individual more than 40 years of age, this is slightly inclined towards the higher side, that is that's non-Gaussian distribution. So measurement can be direct, that is not possible in a clinical setting, that is by manometry, or most commonly used as tonometry, that is the way of indirect measuring the IOP. So the IOP measurement, the indirect measures are the applanation, test, indentation, rebound or dynamic. The applanation can be again divided into non-contact and contact type. The most common non-contact type is NCT or NCT, and the contact one is the Goldman tonometer and Perkins. So what is the difference between indentation and applanation? In indentation, the shape of deformation is a truncated cone, and it displaces large amount of intraocular volume, and the prototype is short tonometer. Whereas in applanation tonometer, the shape of deformation is flat, and it displaces small amount of intraocular volume, and the prototype is Goldman. So the gold standard is the Goldman tonometer. It has parts. It has biprism. This is the biprism, the prism holder, and the housing, and the adjusting knob. So what is the principle? The basic principle is imperfect fixed law. To get a perfect, to apply for imperfect fixed law, the object should be perfectly sphere, enough dry, and perfectly flexible and infinitely thin. But in case of human cornea, these criteria are not satisfied. Hence, the formula was modified. That is called modified imperfect fixed law. Here, the capillary force, that is the surface tension and corneal rigidity, and the inner corneal surface area of applanation came into the action. So for a particular at inner surface area of 7.35 millimeter, the surface tension and the corneal rigidity balances each other. To get a inner surface area of 7.35 millimeter, the applanation area should be 3.6 millimeter. That's why the area of applanation is fixed in case of Goldman applanation tonometer. So the technique wise, as after putting the proper again, the stain the fluorescent strip, no disinfectant residue should not be left on the tip of the applanation tonometer. Cobalt blue using slit lamp, around 60-degree orientation with cobalt blue filter, diffuse illumination and 10x magnification. The prisms are adjusted so that the inner margins of the semicircle overlap, and the reading is multiplied by 10. What are the various tips and patient factors? Patient should look forward at a distant object, and head should be leveled at the marking. Squeezing of the eye, upward eye movement, breath holding or apprehensive can cause high reading. Physician should be the physician's point, that is the index finger put on the superior orbital rim, and the undue pressure will cause high IOP. Repeated measurement can decreases the IOP. So these are the kind of measures you can get. The first one is the ideal one. That should be the adequately measured. The second one is an overestimated one, and third one is the distorted due to eye cylinder. The fourth one, D1, is the lower underestimation. E is the overstrain. F is the understrained one, and G is the spheres are not bisected properly. So source of error, the underestimation can be in thin cornea, corneal edema, decreases clear rigidity in case of high myopia, inadequate use of fluorescent strips, and overestimation can be in thick cornea, corneal scarring, and high corneal astigmatism, excessive fluorescence, and pressure on the globe due to squeezing or upward eye movement. Another one is the Perkins tonometer. The principle is same as of Goldman applanation tonometer, which can be used in children, especially evaluation under anesthesia, or the adult which cannot sit on the slit lamp. The other most common is the indentation tonometer. The prototype is short. It has a plunger, holder, and handle. The weight can be added like 7.5, 10 milligram, 15 gram, and the other one should have that conversion table also. The method is after anesthesia, patient should be in supine position, foot plate applied vertically on the cornea, on holding the handle, and the needle oscillate and the midpoint of exertion is taken as the reading. Then use the conversion table. The other common widely used by non-glaucomatologists as non-contact tonometer, which uses an air puff to deform the cornea. The time or the force required to create a standard amount of corneal deformation is measured by electronically and given as the reading. The other one is the rebound tonometer, that is eye care, which is portable, which no anesthesia is required. It has a magnetized probe that is 1.8 millimeters plastic ball, which has very fast and that's why no anesthesia is required. It can be used in children. The main advantage, it can be used in children as an OPD procedure also. The other one is the ocular rebound analyzer, ocular response analyzer, which uses a rapid air pulse. There is an indentation, there is a deformation with slight concavity, then the cornea come back to the normal. There are two readings obtained, and the difference, the average of the two readings is calculated as the IOP, and the difference is calculated as the corneal hysteresis. It is the main disadvantage of the instrument is that lack of reproducibility within the visit, and it can be good to use for especially in refractive surgery before performing the refractive surgery as a baseline. Another disposable one is the tonopen, the smaller surface area, that is 2.36 millimeter of mercury millimeter square. The other Siltram held machine is most accurate, the Pascal dynamic counter tonometer, which measures the IOP independent of corneal rigidity and thickness. It has a probe of a surface area of 10.5 millimeter, and it applies a constant force of 1 gram. The main advantage is that the surface of the tip matches the counter of the cornea. It's attached to a piezoelectric sensor. The reading it gives us a systolic IOP and diastolic IOP, and the difference is calculated. The tip is also disposable. It is less influence from the CCT also. The newer ones are the contact lens, that is sensible trigger fish. It is highly useful in 24-hour IOP monitoring. It is approved in Europe. The principle is it has contained a silicone contact lens along with a circumferential sensor consisting of platinum titanium stains, and the principle is that any small changes in the circumference of corneal circumference at the limbus correspond to the changes in the IOP and the volume. That is the principle. The other one is the newer one, is implantable one. It can be implanted during cataract surgery in the ciliary sulcus, and it can be also used as a IOP for 24-hour IOP monitoring. Then what about risk infection? Contact tonometry is categorized as semi-critical instrument for ophthalmological use. So it assumes to carry infectious agent. Risk of transmission of infection mainly for adenovirus and HSV. So sterilization is done by soaking or dipping the tip into diluted sodium hypochlorite, that is household bleach, 3% hydrogen peroxide or 70% alcohol. The tip can also be wiped with alcohol, hydrogen peroxide and povidone iodine. 10 minutes continuous wash in running water can remove the hepatitis B virus surface antigen also. Evidence suggested that most widely used is the diluted bleach, which has high
broad efficacy against most of the common infectious agents. The hydrogen peroxide treatment and the alcohol wipe both completely disinfected the tonometer tips for HIV-1 and 2, HSV-1 and 2. Dispose the prism if the prion disease are suspected. And one should observe any crack. Crack it can harbor the more number of disinfectant, also more number of microbes also. One should avoid the crack. One should vigilant about the crack of the application tip. Dilute bleach, any concentration or alcohol, 70% alcohol, or repeated use can damage the tonometer. So reusable tonometer must be checked for any kind of damage. The last slide about the calibration. Calibration is important, especially Goldman applanation tonometer. This is the calibration rod. The center one is the 0 and 2. This is 2 marking 2. This is 6. That 2 correspond 20. 6 correspond for 60 millimeter of mercury. This is the attachment in slit lamp like Zeiss slit lamp. This is the attachment area for Hackstead slit lamp. Then once you properly align, move the knob. Suppose if you keep the knob at 0 position, then move forward. So there is a slight movement of tonoprism. If you move towards, like if you put in the 0, then if you move towards, like increase the rate, like if you move towards 2 millimeter on the knob, that means there is a forward movement of the prism. Then come back again 0, then backward movement, that also lead to backward movement of the prism. That is the ideal one. There is a range in 2 millimeter range is 2 millimeter variation is acceptable for any kind of tonometer. So thank you.
Next presentation is by Dr. Sushmita. She is a professor at Advanced Eye Center, and she is very well known as an orator, and her keen interest is in glaucoma research, especially in children. And her topic is glaucoma evaluation in children.
Thank you, Dr. Shrishti, and thank you, Professor Suresh, for having us on board. So yes, it's my pleasant duty to just introduce you to the world of babies with glaucoma. I want you all to go away with the notion that it's a potentially blinding disease. So it comes into the realm of preventable blindness. And many of these children, remember, will be normal children if only you intervene in time. And our job, it's one glaucoma where we don't have a target intraocular pressure, we probably have a target vision. And preserving their long-term vision is the real challenge. So even if you manage to control them, if you don't take care of their corneas, they're not going to, it's going to be of no use at all. So why bother when the magnitude is so less? And remember, best corrected vision less than 3/16, a child less than 16 years is the definition. Because it is the second largest cause of blind person years, simply because the number of years that this child is going to remain blind is so high that childhood glaucoma or even ROP are second to cataract in terms of number of blind years, which means blindness into the number of years that the patient is going to remain blind. So it's been a recent worldwide recognition of the importance of childhood glaucoma. So slit lamp examination is difficult, but it's surprising what you can do once you put your heart into them. And this is one part of glaucoma which rules by the heart. So these are small babies, and snapshots in our clinic right down to 2 or 3 year old children can be examined on the slit lamp. You can do a gonioscopy. You can make them do their fields by the time they're about 6 or 7. It's fun working with them. You can get their visual acuities, and you can pretty much do their fundus evaluation. So by the time you're with them and they grow up with you, they come straight on the slit lamp and they want to see you through that. So the babies are your friends, really. So we look at diagnosing it, a bit about the classification. So remember, childhood glaucoma is a potpourri of many, many conditions, and it's just one ocean into which everything has been put, and they're not all the same. So the first thing is to suspect and diagnose. So of course you need to look at everything that you would see as an ophthalmology person: cornea, degree of tearing, photophobia, discharge, and intraocular pressures, of course. So see, this child comes to you with hazy corneas and large eyes. So start suspecting that there's ophthalmos and the steamy cornea could be because of high pressures. You need to be able to look at the posterior segment, and if it's not visible, you need to do an ultrasound. So many children keep coming. This child is not crying, but the mother says that he's constantly watering like that. So photophobia, blepharospasm, tearing. That's the triad for a developmental or a congenital glaucoma, so you remember that. So these are the hazy corneas. Now Harp's triad, your textbooks will say, is usually circumferential. It's not true. You can have absolutely circumferential with the limbus. You can have it directly across the pupil. You can have anywhere the descendants is pulled and torn, and that's what causes a Harp's triad. So this is actually a sine qua non of congenital glaucoma. So so this is what if you put him on the slit lamp and you take retroillumination pictures. These are curled up tears in the descemet's membrane which stay even after pressure control. So this entire corneal haze and everything has subsided. But this Harp's triad scars. And the importance of that is that it might lead to astigmatism, which you'll need to correct later, and require rigorous amblyopia therapy. So this is the UBM. This is what the Harp's triad looks like, just to show the curled up descemet. This is what it looks like in this child. This is a large tear. Sometimes they come with acute hydrop. So if you have a white cornea and the mother says that do din pehle theek tha and today he's white, be sure that it's likely because of a very, very stretched descemet which allows the water or the aqueous to just seep in. Sometimes they can come scarred like this, and then it's a really uphill task because you need to do something about the corneas as well. So quickly, this is the CGRN classification, the Childhood Glaucoma Research Network. You will be asked that because it's been adopted by the World Glaucoma Association and the American Academy. So all new textbooks and all new classifications will have the CGRN classification, and if you know it, then it shows that you've done your reading. So basically it's primary and secondary. I leave it at that. Just go back, Google it, and you'll be able to see. It's an easy classification to do. So I'll just go on to what we do with the EUA, because sometimes the babies come to you small and you can't have them seen on the slit lamp. So it depends on various factors. IOP is only one of them, but remember in children it's probably the least important. So we'll put it at the bottom. You have to look for other signs: the corneal diameter, haze, the cup to disc ratio, evidence of dysgenesis on gonioscopy, and in the absence of which you need to re-examine at 6 weeks. So this is the sequence. We do tonometry first, not because the IOP is the most important, but because the anesthetic agents can affect your intraocular pressure in children. So the minute the anesthetist puts in a mask, before they intubate or put in an LMA, you tell them the minute the child is immobile, you just take the pressures first. Then once they intubate, then you go in to do your corneal diameters, anterior segment evaluation, gonioscopy, disc, retina, axial length, pachymetry, and UBM. Since we are lucky, we have it in the OR, but if you can do it, it's a huge thing when you can't see the anterior segment. So this is our usual EUA trolley, which we have all our things on once, and it's a semi-sterile thing. So don't have other things put on it. And this is your kidney tray with all your speculums and calipers, etc. So these are things which you will be asked, so I'm just putting it there. Any glaucoma, any child with a corneal diameter more than 11 millimeters at birth, 12 millimeters at 1 year, and 13 millimeters at any age is suspicious for glaucoma. So keep that in mind, because the child's eye is elastic and the eye expands in response to raised pressures. So the Perkins tonometer or the tonopen, but we prefer the Perkins. It's difficult, but it's possible in a hungry feeding child, even in the clinic. Now, of course, we have the eye care, which has made our life much more easier. But remember, the mean IOP in anesthetized newborns is 11 millimeters. So don't go away thinking that 21 millimeters of mercury is what is the cutoff for glaucoma. In children, a newborn has an IOP of this much. So usually the cutoff is about 15 or 16. Any baby with an IOP more than 15 is suspect. She also has a problem because a foot plate is not adapted to a very disturbed cornea, so it's best avoided in children. So this is just a chart of different IOPs, and you can see that even up to a year, it's rarely more than 12 or 13 millimeters, so that's the cutoff, that's why I showed that. So you need to look at the cornea for clarity, stretching, corneal diameters, and there is a corneal clarity grading as well, which makes it a little more objective, because post-op, I would often ask, iska pehle kitna tha grading? So the grading was 3 and today it's 1, then it's good. Right. So this is the anterior segment evaluation. Remember, detailed examinations under the microscope and iris features such as hypoplasia, congenital ectropion UVA, even aniradia, even iris processes are very, very important for you to know what you're dealing with. So gonioscopy gives clues. We do a gonioscopy of every child, no matter how hazy the cornea is under the microscope. Many times you can get a fair idea. Usually in a normal, this is a normal kid, you'll have a flat iris insertion and you'll be able to see the ciliary body band, as you would in adults. But if you have a glaucoma in dysgenesis, this is a type 1 angle where the TM is just visible, and this is a type 2 angle where the iris is inserted anteriorly. So what does dysgenesis mean? It means the iris has not gone back during development and has stayed up there, so the trabecular mesh hasn't developed, and that's why the glaucoma has happened in the first place. So this is a snapshot from our microscope. We always try to take pictures through the central mirror of the gonioscope because it's the easiest way to then look at it as it goes on. But remember, even if your cup reverses in glaucoma, the glaucoma damage does not reverse. So don't go away thinking that a 0.6 cup has become 0.3 and now the glaucoma has reversed. The damage has occurred, it has reversed because the eye is elastic and the lamina cribrosa has moved forward. But very often you see in babies the disc reversing. So just quickly, the UBM is something which helps us aid diagnosis. So this is a Peters anomaly. You see the anterior segment of the right eye and the left. This is one in which it would be wise to let it be because the other eye is there. The other eye has just received an optical iridectomy. You can see the rest of the cornea has cleared, and the child is actually going to school with about 624 vision while waiting for an OPK. So don't say that we don't have eyes and we're going to wait for an OPK and let the child become 5 years old. By then the battle is over. So you need to intervene and intervene early. Right. So of course training the child, we've already seen that. So to summarize, it's a challenge. But early diagnosis and treatment holds the key, and you need to have your level of suspicion very low. Constant evolution and ideas make it a better treated condition, but it's not a dismal prognosis. Many of these babies become normal adults as they grow up. Thank you. I think I now invite Dr. Srishti for his talk. Dr. Srishti is professor in ophthalmology at PGI with us, and so he'll be taking the next.
Good morning. My sincere thanks to Dr. Suresh and his faculty team from Hyde Codman GMCH. So, I'll be talking about laser application in glaucoma. So, there are lots of applications of lasers in eye. But today's teaching program, I will be discussing its application specifically in glaucoma. So, various options for treating glaucoma, we have conservative, lasers and surgery. Treatment indeed helps, as is indicated by various literature studies also, like this ocular hypertension study group. The patient who were treated, they had 50% less incidence of developing glaucoma. Then early manifest glaucoma treatment study showed us that treating the glaucoma patient reduces the risk of developing advanced glaucoma and preserve the vision on the long-term basis and also preserve the visual field. So, going by the history, lasers have been in use since last 50 years. First time the concept was given by Krasnov, and Weiss and Wittner, they refined the concept. And since last 2 decades, we have trabeculoplasty with selective laser also in our armamentarium. So, why laser? So, there are a lot of side effects of medications. There is compliance problem, then cost factor. And surgery itself has perioperative and postoperative complications. So, where does the laser fits in glaucoma? So, selective laser is as effective as primary treatment with medications. So, various indications in glaucoma are YAG laser, peripheral iridotomy, not only YAG but we can use organ also. Then laser trabeculoplasty, then ALPI, organ laser iridoplasty, then transcranial cyclophotocoagulation, endoscopic cyclophotocoagulation, iridolenticular synecholysis, BAP modeling for a large depth, then laser suture lysis, and ND-YAG laser highlight botomy. So for laser iridotomy, the primary indication is any angle closure glaucoma, and we have two types of lasers. One is YAG, that is Q-switched ND-YAG laser, and other one is KTP 532, that is organ laser, that can also be used. Now, these are the settings for organ and YAG has advantage that we can do it quickly, and its size, target size is large and less energy is used. And we have to use a drop of pilocarpine at least 15 to 20 minutes prior to doing the procedure. So commonest indication is the pupillary block. So when there is a forward going of the iris due to more impact between iris and anterior surface of the lens. So indications are prophylactic in angle closure glaucoma, acute angle closure, symptoms of subacute, appositional closure, then even in peripheral anterior synecdoche, increased IOP and closure if it is detected after dilation of the pupil. Then anxious patient, in that case, even if it is PACS, we should go for laser. Some of the contraindications are significant corneal edema, then flat anterior chamber, or completely angle closure, or angle closure glaucoma that is not caused by pupillary block. So we have to put a preoperatively a drop of pilocarpine, and postoperatively also we should supplement it with steroids and a drop of iodine to prevent the IOP spike. And endpoint is very important to see the endpoint in LI. Pigment epithelial storm and lens capsule visualization and clear iris illumination through the defect. Then some of the common complications are though transient like hyphema, iritis, increased IOP, and of course others also. Second is the laser trabeculoplasty, and here we have two lasers. One is organ and other is selective laser. And there are inherent advantages of selective laser which have been in use since last 2 decades. Here we target the trabecular meshwork. So, trabecular meshwork, basically there are, it is classified into 3 groups. Most inner one is uveal, followed by corneoscleral, then juxtacanalicular meshwork. And the cell size decreases from inside out, and cells are very narrow, adjacent to the Schlemm canal.
So we have time till?
So these are the various pathophysiological mechanisms described: mechanical theory, cellular theory, and biological theory.
So,
And ALT, organ laser, causes a coagulative type of necrosis following laser burn. And its mechanism is the SLT. Its mechanism is specifically targets the pigmented cell, that is melanin. So it creates intercellular channel. So there is no necrosis and there is no scarring. So that's why it is a repeatable laser. And even microscopically, you can see that ALT causes a scarring because of its mechanism, that is coagulation, whereas this SLT, this doesn't cause scarring as it selectively targets the melanin and creates the channel. So, but at that point of time, you cannot see any points, and the end point monitoring is the Chapin bubble formation. So even glaucoma research trial in the past has shown that lasers do have advantage in the glaucoma management. So indications for trabeculoplasty is it can be used as adjunct to medical therapy, then as an initial therapy also, and patients who have poor compliance and patient not willing for surgery or wants time to decide for surgery, and in pregnant ladies. And we can use it in open angle, pigment dispersion, PACs, possibly steroid also, and post-LI PACD also.
Some of the contributions are inflammatory glaucomas in uveitis, NVG, or this is PSCD also sometimes, and anger sachet glaucoma. So we can use in ALT for Goldman mirror or organ laser settings are as given. These are higher than the selective laser. I will be discussing later. And complications related to organ laser are there can be spike or progression of the visual field, iritis, PS, and corneal endothelial damage. So on short-term basis, the initial success varies from 65 to 95%, but there is attrition, and over 5 years, the success rate comes down to 50%. Coming to selective laser, advantage of ALT is that it has got large spot size and very less time, and even power use is very less. And here the end point is cavitation bubble. Usually we keep the power a point less than the where the cavitation bubble is formed. That is called champagne bubble. So comparatively, energy levels are much less in SLT. Spot size is larger, 400 micron compared to 50 in ALT, and exposure time is very less compared to ALT. And it is a repeatable laser. We can repeat it later on. So advantages of SLT are safety and efficacy. Safely and efficacious reduces IOP in a single office procedure, and only 15 to 20 minutes are required. Patient is comfortable. Full effect is seen in 3 to 4 weeks, and it is cost effective, and there is a low compliance problem. That is a single day procedure, and its effectiveness is as good as prostaglandins, and both ALT and SLT reduces the IOP by almost 20%, and success rate in both is equal. It can be used in PECs also, but failure is more at the more subsequently formation of pseudocoagulative material again. So in PDS, less of the energy is required as its mechanism actually is it targets the pigmentary cells. So some of the contraindications of trabeculoplasty are corneal edema, complete angle closure, younger age, and some secondary open angle glaucomas like uveitis or angle session glaucoma. And we can use retinal lens or Goldman 3 mirror, and we use contact lens without magnification. So energy levels are more required in blue eyes and less in black and brown eyes. Literature shows that there is attrition over the time, both ALT and SLT, and by 5 years the success rate comes down. But some of the studies still quote that it is maintained above 50%. So these are some of the studies with attrition rates. Another procedure is organ laser peripheral iridoplasty. This is a procedure used for high insertion of the iris where we cannot visualize the angle. So as a first step, we go for organ laser trabeculoplasty, and we use organ laser because it causes coagulative necrosis and shrinks the peripheral iris, so that later on we can perform the other angle procedures. So here 20 to 24 spots are applied over 360 degree. Another laser is micropulse diode laser trabeculoplasty. It is 810 nanometer diode laser, uses near infrared, 100 laser spots are applied, and there is a relaxation period of 1.7 in between the two lasers, so that the temperature comes down to the basic level. Other procedure is laser cytophotocoagulation. Most of the time it is reserved for the eyes with very poor vision or with painful blind eye, and this has given us advantage that we can save the eye cosmetically. Initially we used to eviscerate most of the eyes. So indications are painful eye, patient unable to undergo filtering surgery. Sometimes we do supplement with some useful vision also. Failed prior filtering surgery and at high risk of failure for PEEP filtering surgery. In these patients also we can go for partial DLC. So preoperatively retrograde anesthesia is required, and post-operatively we have to patch and use some dilator drops like long-term dilator atropine and resume the glaucoma medications because it takes time to be effective. So these are some of the complications related to cyclophotocoagulation, iritis, pain, conjunctival burns and others. Now another new laser is endoscopic cyclophotocoagulation. Endolaser probe is introduced into the anterior chamber. Ciliary body is identified and coagulated. But it is an interventional laser. We can do it at the time of doing some other surgery like cataract surgery or some other uses of the lasers are redo-lenticular synechiolisis. We have sometimes synechi formed leading to secondary and pupillary block. So we can use that there. Or sometimes large bleb. To limit the bleb, we can use the laser for bleb remodeling of overhanging or huge bleb. Then post-trap, we can use it for suture lysis. And in some condition like malignant glaucoma, we can use this laser for laser highlight phlebotomy. So, in conclusion, lasers are proven to reduce the IOP. It reduces the number of drugs required, effective as primary as well as adjunct therapy, and laser like SLT can be repeated. It is safe, office-based procedure, cost-effective, and there is no problem of compliance as it is a one-time procedure. Thank you. This is the end of it.
May I invite Professor Sushmita Kaushik ma'am for the next talk, that is about newer anti-glaucoma drugs.
Okay, thank you, Faisal. Right, so thankfully glaucoma is one condition, like many others, where there has been an evolution of drugs, though it has been sort of stagnant for the last 25 years. So you know the options for management are medication, laser and surgery. So we'll be looking at the medication part because each modality has its own set of challenges. So topical drugs are usually the first line treatment in glaucomas, and the existing four classes are prostaglandin analogs, beta blockers, alpha-2 agonists and carbonic anhydrase inhibitors. So these are what was there. In addition to, we had pilocarpine, which is slowly not being used, but it was a very, very good drug to start with. So the new class that has been introduced is a Rho kinase inhibitor or the ROCK inhibitor. So by the time you would be practicing, I'm sure this would be almost your first line because it holds a lot of promise. So Rho kinases are enzymes that control cell shape and movement, and they lower intraocular pressure by relaxing the trabecular meshwork. So that's the property that has been taken advantage of, and they increase the conventional outflow. So remember, the two outflows are conventional through the trabecular meshwork and the non-conventional through the uveoscleral outflow, which is taken care of by prostaglandin analogs. So this, the ROCK inhibitor, takes care of. And the other one, of course, is pilocarpine, which does go through the conventional outflow. So it's only since December 2017 that it was FDA approved and approved for marketing. So why do you need new drugs? Now the problem is that the cost and availability is a problem. It's not available too easily, it's expensive. Even if you can afford it, patients are not compliant. And even if they are compliant, many times the drugs are refractory to the glaucoma is refractory to the drugs, and the patient simply doesn't respond. But even if you can afford it, if you're compliant and it's working, even then you have allergy and side effects to deal with. So you can't use because of severe allergy. And this, the last one, any guesses? Which drug do you think this gentleman must be using? The last, can you see? Yeah? Huh? Mixed responses, bimatoprost is the thing which is going to cause. You even have kajal nowadays, bimatoprost kajal, so that you can have long, lustrous lashes like this. And I'm not joking, it's available. So, benzalkonium chloride causes dose-dependent toxic effects on the ocular surface. So, these are typical BAK, not to do with any drug. Follicular conjunctivitis, more in the inferior fornix because you pull down the inferior fornix to put your drug. So that's your sine qua non of BAK toxicity. Then you can have side effects of ocular anti-glaucoma drugs. This we've shown Lumigan rather bimatoprost. This periocular pigmentation and this periorbital retraction is most commonly seen with brimonidine. So this is a glaucoma drug side effect. So whether you have glaucoma drug side effects, whether you have BAK or preservative side effects, the net result is that you can't use it. So what are the new classes that we have to, and the idea is that you give less and less of a drug so that for the same amount of pressure reduction. I told you Rho kinase inhibitor, that is one, and the other is a latanoprostene bunol. So these are the two big things which have come recently. The Rho kinase inhibitors are netacidil and ripacidil. So it's available as Ropressa, and Ripatec is ripacidil, which is available. Netalo is netacidil, which is available. And Reiki is again netacidil, which is available. So these drugs are now available in India for us to use. We've started the use of Netalo and Reiki quite often. And there are varying studies to show whether Ripatec is better than the other, but we found that Netalo is better tolerated. So the ROCK inhibitors we've already talked of. It lowers IOP by relaxing trabecular meshwork and increases conventional outflow. Latanoprostene bunol, on the other hand, is not available in India as yet, but should be coming, is known as Vyzulta. So remember that name, Vyzulta. It releases nitric oxide. So these are nitric oxide releasers, and they relax trabecular meshwork again, but not by acting on the cell shape, but by nitric oxide releasers, and again increases conventional flow. So these are the two main classes of drugs which have been recently introduced. The other thing that we are looking at is Rocklatan. Rocklatan is netacidil and latanoprost. We think it will be a very good combination because one is increasing conventional outflow and the other is increasing the uveoscleral outflow. So working in tandem together. So for me, at least theoretically, if I have a Rocklatan in place and then I have timolol or dorzolamide, which reduces aqueous production and increases both outflows, that should be a very good combination for medical management. So that's how you decide what to do. What is known, netacidil increases outflow, also decreases production of aqueous, and also decreases episcleral venous pressure. So it's like a wonder drug where glaucoma is concerned if it really does all that. So just a bit about what is ROCK. It's a naturally occurring serine or threonine protein kinase and promotes assembly of actin stress fibers and focal adhesions within the trabecular meshwork. So anything which inhibits ROCK doesn't allow the trabecular meshwork to be so tightly packed, and that's why through the spaces aqueous can flow out, right? And netacidil is an inhibitor, and it's an amino isocholine amide that also inhibits the norepinephrine transporter. So that's how it also does the other things that it does by decreasing aqueous transport and all that. So this is the mechanism. These are the histological pictures that you'll see. That's a compact trabecular meshwork up there. And when you give a ROCK inhibitor, this trabecular meshwork just, sort of falls apart and the cells go apart so that there's more space for the aqueous to flow out. Okay, so these are the three identified mechanisms. The first is, of course, conventional outflow, just to reiterate. Then NET inhibition, norepinephrine transport is required for aqueous production. So if you diminish that, it decreases aqueous production, and it also lowers the episcleral venous pressure by vasodilatation. Now this vasodilatation is the one which is responsible for the redness. The redness that you see with ROCK inhibitors is not due to ocular allergy. The redness that you see with these drugs is because of vasodilatation, part of the action of the drug itself. Therefore, the patients don't complain to you until they look into the mirror, because they don't have subjective symptoms, because it's not allergy. The redness is because the episcleral venous pressure and the episcleral vessels have dilated. So if they dilate to reduce episcleral venous pressure, the conjunctival vessels also dilate. So remember that the dilatation is a property of the drug because of its action on the vessels and not so much an allergy. So to tell the patient that, don't be afraid, this is okay, this is part of the drug. So there's limited experience, but it's promising. This 10-year-old boy, so let's put it in perspective, left eye lost to retinal detachment, a late onset PCG, a best corrected vision of 6/9 and an intraocular pressure of 42 with discs like this. So he underwent a right eye CTT and a right eye AGV after that, so pretty much intractable. He was okay for 3 years. And then he comes back post-COVID recently with a 28 pressure on maximum tolerated medication with Diamox. So we did a limited DLCP, which means you don't treat 270 degrees. I hope you know what DLCP means, a diode laser cyclophotocoagulation. We didn't go in because he'd already underwent 2 surgeries. So we did that. And the IP was 21 on 3 topicals. And then we had this magic drug which comes in. So we said, let's give it a shot and maybe be able to reduce some of the other topical drugs. So this is what he was like after the DLCP. So pretty much normal looking, surface here. And you see what the netacidil has done. You see how pink it is compared to the other eye? And especially if you're going to put it in one eye, then the contrast is a little striking, but the intraocular pressure was 12. So now he is on lepnoprost and timolol and dorzolamide and netacidil, which is 3 bottles. And now we've taken off the dorzolamide so that he's on 2 bottles and hopefully we'll be able to tide him over with just 1 latoprost timolol, which is Zalacom in the morning, and a netacidil at night. And if we can tide over patients with just 2 bottles, it's good. That's what medical management is about, right? So these are the dilated conjunctival vessels that you're going to see, which is what causes the redness. The child had no problem. He just said, when I look into the mirror, my eye looks a little pink. And this is how they usually look. So to summarize, the goals of neuromanagement is to bypass patient factors of adherence and compliance. That's the whole idea. And minimize toxicity. You can enhance surgical success also by limiting fibrosing and minimizing complications. I put that in because you would be doing a lot of MIGS as well. So it will always be a toss-up between starting 2 or 3 bottles versus doing a minimally invasive surgery, ab interno, and sparing conjunctiva and minimizing complications. But that's where the world of glaucoma is heading, which is what you should know. Look at the possibilities and start work on them. Right? Thank you.
Thank you, ma'am. Now we can take some questions from the students.
Yeah, we'll be happy to take questions because I think the next speaker is in there and we have what?
Or we will ask question to you.
5 or 10 minutes? Or I
Yeah.
love to do that. Yeah, please. Come, get to the mic. Yeah.
Right now, do we use rho kinase inhibitor as a first line medication?
No, the rho kinase inhibitor has not been, is usually not as a first line simply because of the significant side effect of redness. So we would start a prostaglandin analog even now as first line, and if it doesn't work, then probably as second line we would start that in addition to a blocker. But we're looking forward to the combination coming up. Yeah, please.
Ma'am, I wanted to ask if it can be used in childhood glaucomas as well.
Yeah, we've been using them. This was a 10-year-old kid only.
Ma'am, usually in childhood glaucomas, the trabecular meshwork isn't developed well.
Correct.
And the mechanism of action for this drug is relaxing the actin filaments.
Yeah.
So,
No, good point. Good point. I think in any case, childhood glaucoma is so much more a surgical disease. So if at all we need medical management, it would be a second or third or something. But in any case, most medical management in children is usually tiding over. But if it's an older kid like this, and in him it's somehow worked, so you just take it as it comes. But you have a point that for a dysgenetic trabecular meshwork, I'm not so sure, but it's not completely dysgenetic, that's also true, so probably the little bit that is there would work or something, and maybe the other actions come into play. Maybe the reduced episcleral venous pressure. So tell me where you would like to use, the childhood glaucoma would you like to use with the reducing episcleral venous pressure? Where you would love to use it? So let me put it another way. Which childhood glaucoma would have raised episcleral venous pressure? Which? Anybody? Any answer? Which childhood glaucoma would present with raised episcleral venous pressure? Sturge-Weber, correct. So if I have Sturge-Weber, I'd probably be happier using Letrozole. Yeah.
Just an add, sorry.
Ma'am, can we use it as a monotherapy? Because in our center we use Natello, but it doesn't work.
Yeah, that's
pressures are more than 30.
That's what. Most people have not used it as first line. It is usually used as an add-on. I'm not sure how well it will work. But obviously the fact that it is FDA approved as an add-on drug, there must have been trials initially where as monotherapy for some strange reason it didn't work too well. Or maybe it was inferior to the usual prostaglandin and the other beta blockers. So possibly it is that.
In our center we use Nitello in pressures above 30, but it doesn't give us pressure, target pressures.
It didn't seem to work. We need a large body of patients to be able to say whether it really works or it doesn't.
So just an addition, there is rocket trials has come up, 1 and 2 also, and 3 and 4, that compares the ROCK-kinase inhibitors with timolol. The study also found that this moreover equivalent to the action of like IOP reduction as of timolol only. So that's why it's not effective as the first line prostaglandin.
Have early glaucoma like ocular hypertension where only limited pressure lowering is required, maybe around 20% target pressure. So I think you can try there. But if it is more than that, then you have to go for prostaglandins or add-on.
So I think we'll pass on to the retina section. Parul? Okay.
Any other question from students?
There's one more question? No, there's one. Okay, so we can pass it on, we suppose? I think we'll pass on to
Yeah.
Dr. Vishali or Dr. Rima, please join us here. We are going to miss Dr. Dogra. He somehow could not join today morning. Dr. Gaurav has some important work he has to leave. So I think there's slight change in the order, the sequence. We'd have Dr. Gaurav coming first with his talk on what's new in the intravitreal drug armamentarium. Dr. Gaurav, please.
Thank you, ma'am. I must like to thank Dr. Suresh for giving me an opportunity for this meeting. So I will be speaking on comparative analysis of anti-VEGFs, protocol T and real-world evidence. So the protocol T was a DRCR-led study, which was a randomized head-to-head trial of various anti-VEGF agents for visual impairment due to center involving diabetic macular edema, where they compared the efficacy of 2 mg aflibercept versus 1.25 mg intravitreal bevacizumab and 0.3 mg intravitreal bevacizumab, and the primary outcome was the change in visual acuity from baseline to 1 year. So what was the dosing schedule? So the patients were scheduled to receive either the sham or study drug every 4 weeks. So during the first 6 months, that is 24 months, so all participants received monthly injections unless the visual acuity was 20 by 20 or better, and the central subfield thickness was better than eligible threshold, that was 250 microns on the Zeiss status OCT. So what was described as improvement or worsening? So if after the injection there was 5 or more letter gains, that is 1 or more line on the ETDRS chart in the visual acuity, so or there was a 10% or more change in the central OCT thickness. So this was described as a significant change. So if there was improvement and worsening from the last intravitreal injection the patient was injected, if there was no improvement or worsening was observed after 2 consecutive intravitreal injections, and the patient condition was described as normal, that is the patient achieved a 20/20 vision or the central subfield thickness was alright, the treatment was deferred. So if the patient was described as stable, that is there was no improvement or worsening after 2 consecutive intravitreal injections, and the patient's condition was not normal, that is patient had subnormal vision, prior to week 24 the patient was injected, and after the week 24 if the patient was stable the treatment was deferred and treatment was reinitiated, that the treatment was given again only when there was worsening of visual acuity lattice score or the subfoveal field thickness. So the laser photocoagulation was initiated at or after 24 weeks for persistent diabetic macular edema based on protocol specified criteria. So what were the main findings from the study? So there were greater visual gains at 1 year in the aflibercept arm. So there was a 13.3 letter gain in the aflibercept arm at 1 year as compared to 11.2 in the ranibizumab arm and 9.7 letter gain in the bevacizumab arm. So if we compare, aflibercept was superior to both bevacizumab as well as ranibizumab statistically at 1 year. So the visual acuity gains continued into the second year, but at second year, at the end of second year, ranibizumab it catches up with aflibercept. So, but if we compare aflibercept and bevacizumab, so there was a significant difference in visual acuity gains at 2 years. So if we look at the central subfield thickness, again, the greatest reduction was seen in the aflibercept arm as compared to both bevacizumab and the ranibizumab arm. So they did a further subgroup analysis. So how did the patients who had a baseline vision less than 20/40 reacted to respective anti-VEGF agents? So at 2 years, there were a significantly greater mean visual gains with the aflibercept as compared to bevacizumab. So at 2 years we see that, so this is the aflibercept arm and this is the bevacizumab. There are significant differences, but not, there was no significant difference between aflibercept and ranibizumab at 2 year point of time. So these differences were not really seen when the visual acuity was better than 20/40. So all of them had a similar graph. So if aflibercept is superior to ranibizumab at 1 year but not at 2 years, so why should we still consider aflibercept instead of ranibizumab for central involving DME when the visual acuity is 20/50 or worse? So the point is area under the curve. So that is that patients who are receiving aflibercept, so they are going to have better visual acuity gains for most of the 2 years period. Or to put in other words, so the curve of ranibizumab will catch up with aflibercept very late. That is at 2 years, the curve of ranibizumab is approaching aflibercept. But for most of the 2 years period, aflibercept has been superior to ranibizumab. So this is just to show the visual gains which are average over 2 years. So if we see that as compared to bevacizumab, the patients receiving aflibercept had a mean of 4.5 letters more visual gain as compared to bevacizumab, and also 3.4 letters more gain as compared to the ranibizumab. So the point is that the patients with 20/50 or less vision who are receiving aflibercept are likely to enjoy better visual acuity for most of the 2-year period as compared to ranibizumab, and this is very meaningful for somebody who actively reads or drives. So to put in other words, ranibizumab is slower to act, so aflibercept should be preferable. So was aflibercept, the other question was aflibercept superior in terms of central subfield thickness in this subgroup? So patients treated with aflibercept experienced considerable reduction in central subfield thickness regardless of the baseline visual acuity. So even in patients with good baseline visual acuity, so there was much greater reduction, 133 microns here in the aflibercept group. However, it does not change into the visual acuity gains. So if we look at the proportion of patients requiring focal or grid laser treatment, so 41% of the patients in the aflibercept group required a focal or grid laser as compared to 64% in the bevacizumab group and 52% in the ranibizumab group. So during the first 6 months of intensive treatment, when injections were given every month for the first 6 months, so the proportion of eyes who had persistent DME, they decreased to 31.6% in the aflibercept arm, 65.6% in the bevacizumab arm, and 41.5% in the ranibizumab arm. And if we do an intensive treatment in the first year, so the number of injections in the second year reduced. So the mean number of injections in the aflibercept arm was 9 for the first year and 5 for the second year, and in the ranibizumab arm it was 10 in the first year and 6 in the second year. So the key summary was that the intravitreal aflibercept, bevacizumab or ranibizumab improved vision in eyes with center involving diabetic macular edema, but the relative effect depended on the baseline visual acuity. That is, if the visual acuity is more than 20/40, so you can use any of the above injections and the visual acuity gains will be similar. However, if the initial visual acuity is 20/50 or worse, so aflibercept was more effective at improving vision over a 2-year period. So their point was that over the 2 years of study, significantly fewer patients receiving aflibercept required focal or grid laser, and if we do an intensive anti-VEGF treatment in first year, so it will reduce the burden of injection in the second years and thereafter. So what does the real world evidence say? I have just put one study here, that is the Cochrane meta-analysis, so which included 24 randomized controlled trials of anti-VEGF agents for treatment of DME in 6,007 patients, and the criteria was the visual acuity was generally between 20/200 and 20/40, and they studied 3 efficacy outcomes, that is number of patients who had a greater than 15 ETDRS letters gain, that is 3 ETDRS lines gain, mean change in best corrected visual acuity, and mean change in the central retinal thickness. So in the Cochrane meta-analysis, aflibercept conferred an advantage of 0.5 to 1 ETDRS best corrected visual acuity over ranibizumab and bevacizumab at 1 year. Right. I'm just going to skip that. So the key findings of the Cochrane meta-analysis were that aflibercept, bevacizumab and ranibizumab were all more effective than laser at improving vision by greater than 3 lines at 1 year, and the level of evidence was high, and patients are more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab. So 36.6% of the patients are likely to gain 15 or more letters with aflibercept as compared to 24.7 for ranibizumab and 27.6% for bevacizumab. So all 1 year efficacy outcomes, that is the visual gain as well as the central retinal thickness, they favored aflibercept over ranibizumab and bevacizumab. And ranibizumab and bevacizumab did not differ in terms of functional outcome, but ranibizumab may be more effective than bevacizumab in terms of reduction of central retinal thickness, and the safety outcomes are consistent between different anti-VEGF agents. So as far as some of the societies have given guidelines, so according to the Euretina Society, anti-VEGF therapy is recommended as the first-line therapy, and aflibercept is preferred if the baseline visual acuity is 20/50 or worse, and it will be equivalent to other agents if the visual acuity is 20/32 to 20/40. So again, the Asian guidelines, they recommend anti-VEGF agents as the first line of treatment, and anti-VEGF therapy should be given as first line treatment for patients with center involving DME with central vision loss. And choice of anti-VEGF agents again depends on the baseline visual acuity. Less than 20/50, then aflibercept should be preferred. So the key summary is that early intensive treatment of DME in the first year leads to meaningful visual gains that can be maintained in long term with a reduced treatment burden. So intravenous aflibercept, bevacizumab or ranibizumab improved vision in eyes with center involving diabetic macular edema, but the relative effect depended on the visual acuity at baseline. So aflibercept is preferred if the initial best corrected visual acuity is less than 20/40, and if the vision is good, so any of the 3 agents can be preferred. So in practice, all of these agents are used by people, and in practice usually we do 3 monthly loading doses followed by a kind of PRN kind strategy for all of these drugs.
Thank you, Gaurav. Am I audible? Dr. Gaurav, if you could just tell us that steroids versus anti-VEGF, that will be beneficial for them, because that's the one question which comes to everybody's mind. Center involving macular edema, should we go ahead with steroids or anti-VEGF? Is there some guidelines? Are there something? What is your preference?
Usually, ma'am, anti-VEGF are the first line of treatment in most of the patients. Usually, in our practice, we are using 3 monthly loading doses of anti-VEGFs. Again, the choice will depend on the cost issues are also there, because the bevacizumab is we're still using bevacizumab, so that is much less costly as compared to the other 2 agents. Although the cost of Eylea has come down because they have an Eylea for You program, so the Eylea and the Lucentis cost the same. So any of these 3 agents, so depending on the visual acuity as well as the cost constraints, so we are going to use, and for the first 3 months we are using a loading dose, and then we shift to a kind of a PRN kind of strategy, and in between if focal or grid laser treatment is required, we add it. So that is what we are doing. And Ozurdex, steroid implants we are using in more of recalcitrant cases, especially if the patient is phakic, we generally tend to avoid it. More preferable if the patient is pseudophakic. So glaucoma is not really a concern with Ozurdex, and if the pressure does rise, it is very limited and can be controlled with 1 or 2 medicines. So that is what.
I'm sure ma'am would have, she would be covering all this aspect in her talk also. Thank you, Dr. Gaurav. I would invite Dr. Vishali for her talk on diabetic retinopathy. It's an honor to have her speak here with us. She's been teacher to most of us, and has contributed wonderfully to diabetic retinopathy management.
Well, very good afternoon, very good noon to all of you, and it's pleasure to, be here. And I was telling Suresh that it's the first time I'm speaking in person after COVID. So really pleasure to be here in Medical College. Suresh gave me a topic of diabetic retinopathy for 8 minutes, so I decided not to confuse you guys and restrict myself to diabetic macular edema. So Gaurav has already beautifully told you about aflibercept and how should you use the anti-VEGF. I'm just going to talk very basic stuff which as a postgraduates you need to know. So when we talk of diabetic macular edema, the first thing, any patient of diabetes who comes to you and says that I have difficulty in reading despite my glasses, so that is the first indicator you know there is diabetic macular edema. If a patient of diabetes comes to you with floaters, which means there is hemorrhage and proliferative component. So this would be the first step, that there is difficulty in reading. You look into the eye and what you would see is, I don't know how it works with you, but our residents love one word, that is dull foveal reflex. Any damn thing in the retina, they just write dull foveal reflex, refer to retina clinic. So that actually, the foveal reflex in diabetic macular edema gets dull because there is accumulation of fluid. So even if you are in the beginning of your career and you cannot appreciate stereoscopically that there is edema, you would have some monoocular clues in the form of hard exudates. You are not able to see retina very sharply, which means there is macular edema. So I'm not saying do fluorescein, but if you happen to do fluorescein, you will find these areas of microaneurysms which are leaking. But if you have OCT, just go through the OCT line scan and you will come to know there is macular edema. So what is causing this macular edema is very important. Before you decide to inject or which injection to give, or to do laser or not to do laser. So there are different mechanisms as you can see here, and this will partly also answer, what Subina was asking. So the main culprit, as you all know, is sustained hyperglycemia. Now hyperglycemia is causing advanced glycation end products, which you all are taught, loss of pericytes, microaneurysms, capillary dilation. This is because of advanced glycation end products, and this you have to know because your anti-VEGF do not act against AGEs. Trials are wonderful, but trials are also, I don't want to discuss all those with you, but trials are not the end of the story for you to follow. Now, when we have advanced glycation products, there are other things which are happening to the endothelium. And endothelium, you should know there are two barriers, outer and inner. This one is affecting mostly the outer, and when the inner barrier gets affected, there is endothelial cell death and finally resulting in macular edema. And then there is a third product which is going on in which VEGF has a role. So you have different chemicals which are acting to cause macular edema, but the basic insult, as you all understand, is hyperglycemia. So if you do not take care of this hyperglycemia and you keep on lowering the VEGF, or you keep on lowering some of these end products by giving steroids, and hyperglycemia continues to work, it will not work. So that is the first step as ophthalmologist, is to control the hyperglycemia. Okay. How do I move forward? It's not going. Okay. So again, when we come to the histology levels, you also have to understand, because as you advance, you will hear people lot about biomarkers, imaging biomarkers, some dots, something, and how you can prognosticate or manage your therapy based on that. But as students, you need to know that it affects all these cell types: retinal vessels, choroid, glial cells, neuronal cells, and when you are seeing different imaging biomarkers, this is because all these cells are producing different changes. Now, when you look at the macular edema, honestly, you do not see what is happening underneath. All these changes are producing just one end result, and that is the development of macular edema. So, what should be the first step when you are encountering a patient of macular edema? First, make sure patient has edema. Secondly, make sure there is no component of proliferative diabetic retinopathy. So once you know it is macular edema, control his hyperglycemia. Besides hyperglycemia, control blood sugar, blood lipids. Now this is the slide you might have seen multiple by many of us. It's published in American Journal of Ophthalmology, and this was the work we did decades ago about how the addition of atorvastatin, and no laser, no injection, because this was done pre-injection era, but just addition of atorvastatin, you can see how the hard exudates get reduced. Now what will happen if you start pushing laser? All these things come and sit in the center of the fovea. This is called foveal migration of hard exudates, and if they are allowed to be there for a very long time, they produce fibrosis. So it's very important not to rush into laser. You can give injections. Steroids are actually preferred if you have lots of hard exudates over anti-VEGF, but systemic control is again very, very important. Now, when you come to OCT, I told you that if you have macular edema, look at OCT. The first step is look, is there anything which is causing a pull, a membrane, a taut posterior hyaloid membrane. If there is a tractional variety, don't do anything. Don't inject, don't do laser. So it will require surgery. So you can see this patient did receive injection, not much response, and you simply remove the membrane, and post-vitrectomy you will have a resolution of tractional variety of macular edema. Now you have non-tractional variety, and Gaurav told you beautifully that you look at the visual acuity and decide which injection to give. But before looking at the visual acuity, first just see whether macular edema is involving the center or not. Simply because the vision is 6/18 does not mean that vision is low because of macular edema. There could be macular ischemia, there could be scar, there could be hard exudates, there could be unrelated pathology in that patient, or there could be simply amblyopia. So you first have to see whether macular edema is involving the center or not. If it is center involving, then you go in the direction of injections. If it is not center involving, then lasers would be the primary choice, and of course the systemic control would be valid in both the situations. For lasers, you can do systemic control and wait for 4 to 6 weeks before doing laser. For injection, you can have both the things simultaneously. As long as your blood sugar is less than 200 as per AIOS VRSI guidelines, you can inject, and you can also get the control simultaneously. And this is it's in American Journal. All of you who want to know more about it can read about it, that how do you management paradigms. So if you have diabetic macular edema, clinically you may be able to see. You again can have mild to moderate or moderate to severe, and on OCT, as I showed you, you can see whether there is center involvement or no center involvement. If it is no center involvement, you go to ETDRS guidelines, and ETDRS was all about laser. So when we say ETDRS guidelines, we mean laser. But if you have center involvement, then of course you go for the anti-VEGF injections. Protocol I has shown that patients who are treated with ranibizumab with prompt laser or deferred laser actually had a better visual outcome than giving laser alone. So there is a definitive role of anti-VEGF in management of center involving macular edema. My last leg of talk is about the OCT biomarkers and about which injection to give. So, you know, the world is moving towards precision medicine or personalized medicine, and we in retina are fortunate because some of the imaging biomarkers can help us in guiding towards management. As postgraduate students, honestly, I don't think you need to know it, but just, you know, in passing. So there are three critical questions when you are looking at OCT. You know, what are the biomarkers you should be looking for? So you look for actually this line, this segment is very crucial. Outside the external limiting membrane, if there is disruption, the vision is going to be poor. If these layers are all merged together and you are not able to see them separately, it's called GRIL. Disorganization of inner retinal layers. That has poor prognosis. And if you are seeing lot of hyperreflective dots, that is another, bad sign. So this is the kind of the edema you would inject. And I don't think I need to teach you all this, but the thing is macular edema is not only caused by VEGF, so anti-VEGF is not the only answer. So you can look at some of the biomarkers, decide which one to give. I don't think you needed to know it as a student, but only thing which you need to know is it has multifactorial etiologies, so you've got to take care of all the etiologies: systemic control, hyperglycemia control, and atorvastatin not only takes care of hyperglycemia, hyperlipidemia, it also causes the tightening of the barrier, endothelial barrier. So atorvastatin has a double-edged role when you are giving it in patients with macular edema. So that's all for now. If you have any questions, I'll be happy to answer.
Thank you, ma'am, for a wonderful talk as usual, and I'm sure everybody is benefited by that. So any questions?
Any questions, I'll be very happy answering. Whatever. There none?
Ma'am, is it essential to have OCT to call edema center involving or center not involving? Or a thorough examination can give us the answer for that?
The classification which came was based on OCT. But I think clinically also, if you are seeing cystoid spaces right in the center, it is center involving, yes. Okay, thank you. Arang, and Dr. Subina is going to speak on management of choroidal melanomas. You know, Subina is the lead expert here doing all plaque therapies and everything, so we look forward to her talk.
A very good afternoon to all of you. It is not showing that? All right. So we are going to be talking about what's new in the management of choroidal melanoma. So starting this talk, I would presume that you know basics about choroidal melanoma. We all know it's the commonest intraocular tumor in adult eyes. And it's the main problem in choroidal melanoma comes that this is known for undetected micromets. About 50% of these patients would not be with us in another 10 years. So what's new? Everything is targeted now towards decreasing these mets, increasing the visual prognosis. So I would be covering my talk under following heads. One is in the diagnosis of choroidal melanoma. We should be able to tell when the nevus transforms into melanoma and we have to intervene. Second aspect would be melanoma classification, which has really undergone a major change in these years. Melanoma therapy, various therapeutic modalities which are new in our armamentarium, we would be discussing. Now coming to the risk factors of nevus growth to melanoma, if you remember a mnemonic, to find small ocular melanoma doing images, then on the basis of imaging, you could find the risk factors for this. If your thickness of the tumor is more than 2 millimeter, fluid is associated which is picked up on OCT, or patient is symptomatic, that is vision is less than 20/50, or you are able to see orange pigment. It would be very well visible on fluorescent, fundus autofluorescence, or you see melanoma hollowness, which is acoustic hollowing which you pick up on ultrasonography in the mushroom-shaped mass, or your diameter of melanoma is more than 5 millimeter. Well, these are the risk factors for melanoma, for nevus transformation into melanoma. Now, depending on the number of risk factors, now this is come new, you add to objectivity. In case there's one risk factor present, then there's 11% of chance of the melanoma to be turning, of nevus to be turning into melanoma in another 5 years. If there are 2 risk factors present, it is 22%, 3 risk factors present, it's 34%, 4 risk factors, it is 51%, and 5 risk factors, it is 55%. So once you see all these risk factors, which is very easy to remember with the mnemonic, you see what is the chance of this becoming a choroidal melanoma, and then you have a close follow-up for that patient. The classification has again undergone a major change. We used to follow American Joint Committee cancer classification, that is AJCC, which was based on tumor size, ciliary body involvement, extraocular spread. Then we had categorization and subcategorization of choroidal melanoma. But now it has been seen that this classification is not very well associated with the prognostication of the patient. So newer thing which has come up is Cancer Genome Atlas classification, which is classifying choroidal melanoma on the basis of the biopsy finding. The FNAC is done from the melanoma, and then you do the genetic evaluation, which has really become very, very important these days. We are slowly shifting to this genetic evaluation. At present, it is quite expensive in India, but still slowly our genetic lab is going to take up very soon these this evaluation of chromosome 3, 6, and 8. And it has been seen that monosomy 3 is what comes to your mind once you talk about choroidal melanoma. Molecular profile of monosomy 3 impacts overall survival negativity. But however, you must know this is the overall survival of the patient and not the ocular survival. If you are doing brachytherapy, your tumor may be improving, but you cannot tell the patient, well, you will not have mets in the coming 5 years. That depends on monosomy 3. If patient has monosomy 3, you will have close follow-up for this patient. This was AJCC classification, which was quite complicated, and you relied on the online algorithm to tell you the prognostication and follow-up. Now with this, the ABCD classification, you have on the basis of monosomy 3, you in fact divide melanoma into A, B, C, and D groups. And C and D groups are bad prognostication signs, where you have monosomy 3 along with chromosome 8q gain. Even chromosome 8q gain in these two are the poor prognosticators. And if you have your tumor following in these two categories, that means monosomy 3 is there, 8q gain is there, these patients need to be followed up quite close to each other. They are called high-risk melanomas, and every 3 to 6 months they would be followed up. And then there is a significantly muted gene, the BAP1 gene, which is again very important nowadays. And 5-year death rate you see increases from 1% in group A to around 23% in group D. And 5-year liver mets, the commonest metastasis in choroidal melanoma is through bloodstream into the liver. So the rate of liver mets also increases from 2% to around 61%. That is why nowadays genetic evaluation of all melanomas becomes a must. Now melanoma therapy, we have all these things which are coming up. Plaque brachytherapy still stays the main therapy which you would be giving. Then you have other therapies, transpupillary thermotherapy, proton beam radiotherapy. These are the newer things which could just be asked there. We still don't have any centers doing it here with us. In India, gamma knife radiosurgery, local resection is being followed now more and more. We don't have any experience in our institute, but yes, South Indian people have just started doing local resection of tumors. Then nanoparticle therapy is another newer therapy. Now brachytherapy is localized radiotherapy. When we are locally giving it, we see the tumor and we apply the plaque on the outer side, and 3D planning is done with the help of MRI and ocular imaging techniques. And then you could be using brachytherapy with ruthenium or with iodine plaques. Ruthenium is going to give beta radiation and iodine is going to give gamma radiation. The penetration of gamma radiation is higher than beta radiation. Therefore, most of the tumors which are coming to us are late. They don't come to us, initial presentation is always missed in India. So by the time they come to us, their height is already 10 millimeter or more than, I would say, whatever I have seen in the past, ever since I have jumped into the practice of choroidal melanoma and all. There was just one case which was less than 5 millimeter. All of these are 5 to 6 millimeter height. They are all high, I mean the height is always higher, on the higher side, 7, 8, 9 millimeter is the average height which you get. This is one patient where you have vitreous hemorrhage, which is seen on this ultrasonography. You have choroidal melanoma. This is in fact the layering patient was lying down, so layering of vitreous hemorrhage. And in this, there was in fact the treatment done was a blind treatment. We could hardly visualize the melanoma once we are doing the treatment. So on the treatment planning system, we could just see the where to put the sutures for these slots. We pushed in, and with the help of trans-illumination, we had some idea where to place the plaque. We placed the plaque, and this patient did wonderfully good. And there was more than 50% reduction in the size of the tumor over follow-up. Then patient underwent past vena vitrectomy for vitreous hemorrhage and cataract surgery, and final vision of 20/60 could be achieved in this. So sometimes the picture could rarely be good as this. Now this is another patient where after brachytherapy, the tumor has dwindled to almost mere flat scar. This is one patient, this is another. So by, I think, more than 6 months, both the patients had, instead of melanoma, they had absolutely flat scar. But along with this, you could have complications of brachytherapy, something like, this is radiation retinopathy, which is very common. Optic disc pallor is also here. So now the newer thing which has come up is that once you do brachytherapy, go ahead with prophylactic therapy. Every 4 monthly inject bevacizumab for another 2 years. If you go ahead with anti-VEGF agents, it has been seen that there is significant reduction in cystoid macular edema, in maculopathy, in papillopathy in these patients, and final visual acuity is also definitely better than no bevacizumab. So here if you see at 4 years follow-up, the final visual acuity was 20/70 in the patients who were injected with anti-VEGF agent for 2 years instead of those who were not injected with anti-VEGF agents. So this is another new thing which has been added to brachytherapy. Now for anterior segment tumors also, we have been trying brachytherapy. This was a biopsy-proven iris melanoma, and we offered brachytherapy, but if you put radioactive sources straight onto the cornea is going to melt away. So what you have here is the amniotic membrane, fingers amniotic membrane buffer technique. You have commercially available amniotic membranes, and thanks to our cornea team, Dr. Ujjwal, Dr. Arya, who offered us their services, and we put this amniotic membrane flap onto the cornea. After that, you go ahead with putting the plaque over this amniotic membrane. Patient is isolated for whatever recommended time was. In her case, it was 3 days. For 3 days, she was in isolation room. After that, you remove this amniotic membrane, you remove the plaque, and look at this beautiful thing. The cornea is shining. This is post-op day 25th. And we are happy that we are able to save the cornea. And of course, we don't expect much improvement at 25 days. Ultimately, this would regress over a period of 3 to 6 months. And meanwhile, the patient would be undergoing systemic investigations also. Transpupillary thermotherapy, normally I told you the tumors don't come to us that early. This is for tumors which are 2.5 millimeter or less in size. So what we'll do here is we can use this transpupillary thermotherapy in the form of sandwich technique. On the outer side, we apply, on the sclera, we apply the plaque therapy. On the inner side, we treat with transpupillary thermotherapy. We apply the spots, and we have beautiful regression in these tumors. Now there are newer therapies which are coming up, charged particle therapy or proton beam therapy. Here you have heavy electrical charged particles, highly focused energy is passed, and this is halted by the solid tumor. Now X-ray, there is diffraction all over. In proton beam, you pass the particles, and wherever there's solid tumor, they are going to block the energy there, and this energy gets concentrated there, and the most of the dose is released, where the region where most of the dose is released is known as Bragg peak. So this also leads to resolution. I mean, this is working well in our melanoma cases. However, we do not have any centers. In Hyderabad, there's a center. Probably they haven't done much for choroidal melanoma. They are doing proton beam therapy. Then there's gamma knife radiosurgery. PGI has the privilege of having gamma knife radiosurgery, but I think they have still not used it in ophthalmology. In this, what you have a precisely focused radiation to pinpoint accuracy. And you plan the surgery for choroidal melanoma. Accordingly, you give around, the melanoma is bombarded with about 200 beams of radiation amounting to 30 to 50 gray total dose. And ultimately, you have resolution. This is good for patients who are unfit for surgery. And juxtapapillary tumor, because it is so much focused that your disc would be saved. Many brachytherapy cases which I showed you pallor of the disc at end of the day, because if you have juxtapapillary tumor, whatever you do, you will get optic atrophy. So these are the newer therapies which have come up for that. Local resection of tumor can be done, exoresection or endoresection. Exoresection would be you can raise the scleral flap and you can then remove the choroid and the retina, everything, and surrounding can be cryoed. It's a very, very heroic surgery. We haven't had chance to do it, but yes, it is done. 1 or 2 cases have been done in India. So this can be done. Then there is nanoparticle therapy. It has come as a big boon. Here what you have, viral-like nanoparticle binds selectively to the tumor, and then you have photosensitive drug. After 6 hours, you will be shining the laser type, the laser light 689 nanometer laser onto the tumor, and you have preservation of vision and destruction of tumor. Here the major issue is the inflammation it leads to. Inflammation is quite alarming, but then you can treat it with the help of steroids. Then, as I said, that choroidal systemic mets are very common in choroidal melanoma, especially monosoma in 3 cases. So it has been seen in high-risk tumors. That means if your cytogenetics show monosomy 3, 8q gain is there, you call it high-risk case. Whatever treatment you offer, it could be triple T, it could be brachytherapy. Along with that, we can start chemotherapy. Dacarbazine and interferon alpha are preferred. Then we also have sunitinib, which is available in India. Now we've just started, we have to start in our institute. It's been tried at some places that you give immunotherapy and targeted, you could give sunitinib, and ultimately it improves your survival rate of the patient significantly. So summarizing, I think we just discussed what are the diagnostic ways to diagnose melanoma, identify the choroidal melanoma objectively. If you follow that mnemonic and you see whether 1 factor is there or 2 factors are there or 3, whatever number of factors, and you can prognosticate the patient. Melanoma classification, it's totally changed. Now it is based on the genetic evaluation. Melanoma therapy, what's new is brachytherapy still is the backbone, but we have newer things which have come up now, which still we have to see them in India. It's not very, we don't have proton therapy, we don't have gamma knife as of date, but yes, we are progressing and we could have still better results in choroidal melanoma. Thank you.
Thank you. Thank you, Subina, for a wonderful, very knowledgeable talk. So any questions for Dr. Subina? If none, we move on to Dr. Reema Bansal, who is Professor of Ophthalmology in Vitreoretina and Uvea at PGI. So Reema is going to speak on what's new in uveitis diagnostics. So in the meantime, if you have any of the questions, we'll be happy to answer.
Thank you, ma'am, and very good morning to all of you. Thanks to Dr. Suresh for having me here. And it's really nice to be back in a physical meeting in the Government Medical College Hospital. So I'll be talking on what's new in uveitis diagnostics. So I'll be talking on both what's in current practice, and because obviously what's new is always linked with what's going on and what's old. So as we know that we have the routine lab tests. Now many times our fellows and our students ask us the importance of these tests. So when you see a patient of uveitis, whether you really should order these tests or not, and many times these are overlooked and not ordered. So the relevance of the complete blood count with differential is that if you're seeing a patient of uveitis, obviously you may have a systemic focus or you may not have. So it's a good idea to just investigate the patient for a complete blood count. It tells you about the underlying systemic infection in terms of leukocytosis or a parasitic infection if you happen to detect eosinophilia, leukemia or certain immunocompromised states. If you have the metabolic panel, I really don't say that you advise them in all patients, but if you're planning to put them on steroids or immunosuppression, it would detect your underlying undetected diabetes, the renal or hepatic dysfunction would be detected, and then you can start your treatment accordingly in some of these few patients. ESR and CRP are few non-specific tests of inflammation, and if they give you some knowledge, it's good. Now coming to the most conventional and the most commonly used test, tuberculin skin test or the Montague's test. I'm not going to put details on this. It's more than a century-old test, and we know that we do it in any patient who's presenting with a granulomatous uveitis of undetected etiology. Now the readings of TST in our setting are taken as more than 10 millimeters to be positive. The common question that comes to your mind is whether to order these IGRAs or the interferon gamma release assays, and quantiferon TB Gold is the commonest among them. These tests have the advantage over the TST in being more specific because of less cross-reactivity to the BCG vaccine and non-TB mycobacteria. However, you may have false positive results because of the ESAT6 and CFP10 antigens which form the basis of these tests, which are found in non-TB mycobacteria. The other limitation of these tests in uveitis is because of the increased cost and limited data available. So this is the limiting factor of their use in uveitis in every patient. Quantiferon TB Gold can be used in place of TST and not in addition to. So if you have done a TST and you have some result available for you, you really don't have to do in addition to TST the quantiferon test. If you don't have the report available or the patient has not done it, you can go for it. As recommended by the CDC, and moreover by the WHO, it has been banned as a screening test because you have the other test in the form of Montague's or the TST as a more reliable and more affordable test as far as the cost is concerned. Coming to the syphilis, which is again a great mimicker, we know we have direct, which are the treponemal tests, and indirect non-treponemal tests. The direct tests are the seroconversion markers. So once the patient has been exposed to syphilis, these markers remain forever positive. So you have TPHA as the commonest among them. So once TPHA positive means you're going to have this patient TPHA positive forever. So that's the reason when you detect these patients with TPHA positive, you treat them, so you monitor them on the basis of VDRL and not a repeat TPHA. The indirect or the non-treponemal tests include the RPR and the VDRL. These vary with the disease load and they become undetectable in a fully treated disease. So we recommend, what is recommended is to do a direct test first, and if positive, as I said earlier, you follow them by one of the indirect tests. Newer testing for syphilis is available in the form of IgG and IgM. So these are the commercial testing for antisyphilis IgG, which has lower false negative and false positives rates than the indirect testing. So if syphilis IgG is negative, patient is not exposed to the disease. If syphilis IgG is positive, you follow with the indirect test, that is RPR, or if RPR is negative, then you check the direct test or the TPHA. Continuing with the serological tests, the IgG and IgM, most useful in uveitis practice is the HIV status. The other we do use, but they do not have any definitive contribution to your practice in the form for viral serology or toxoserology because of varying positivity rates, and most patients who have had exposure are likely to be seropositive. When it comes to sarcoidosis, a lot of time we see the files and we see the reference with the ACE levels being done, and sometimes the decision has been made only on the basis of the ACE levels. So you need to pay attention here. These, the test which is used for ocular sarcoidosis, the sensitivity is 84% and the specificity is 95%. Positive predictive value is only 47% and non-negative predictive value is even lower. So because these ACE levels are not specific for sarcoidosis, a positive test never would make a definitive diagnosis. Similarly, the serum lysozyme levels, which is also another test ordered for suspected sarcoid cases, the positive predictive value is very low, 12%. So although the utility of these indirect tests is very limited in sarcoidosis, their diagnostic accuracy would improve substantially if you've seen these patients and you have a corroborative evidence in the form of radiological evidence. Coming to the various HLA tests, HLA-B51 is associated with approximately 6-fold increased risk of Behçet's disease. And this is found only in 39% of Behçet's disease versus some of the people, even the controls having this variant, 18% of them. So a positive test does not prove the disease and negative test does not rule out the disease. Coming to the systemic rheumatic diseases where you do see these challenges in your uveitis clinic, ESR and CRP, as I said, are important. Rheumatoid factor is another test that we order. Anti-nuclear antibodies are the first investigation commonly detected with clinical suspicion of any of these underlying rheumatic diseases. Coming to the Wegener's or the GPA, you have two variants of ANCA, the C-ANCA and P-ANCA subtypes. So the antibodies to the single-stranded DNA are not specific, but the antibodies to double-stranded DNA are 95% specific for SLE, and they're seen in 70% of these patients. And the anti-Smith antibodies are pathognomonic for SLE, found in 30% of SLE patients. The radiological investigations, we routinely order these patients, these investigations, especially the CT scan, which is now taking over the conventional X-rays in patients presenting with granulomatous uveitis, whether it's anterior or posterior. And CT has, over a period of time and with our own experience, has proven much superior to the conventional X-rays. And in specific cases, if you're suspecting a patient with ankylosing spondylitis, it's a good idea to order an MRI of the sacroiliac joints, which is better than the conventional X-rays if the patient is affording, because the MRI detects the bone marrow edema much earlier in the early part of sacroiliitis, which is not picked up on the X-rays. So continuing with the HLA or the human leukocyte antigen in uveitis, these are more for research purposes, but I would just like to put a slide on this so that you know the relevance of some of these types in uveitis. This is a protein present on the surface of the cells that constitutes the major histocompatibility complex. These genes are located in short arm of chromosome 6, and various HLA haplotypes are known to be associated with different uveitic conditions. As I mentioned, HLA-B51 for Behçet's disease. HLA-B27 related uveitis, we order this when you have a patient of acute anterior uveitis. So this spectrum includes spondylitis, reactive arthritis, psoriatic arthropathy, and IBD. HLA-DR5 for oligoarticular JIA, and HLA-A21 for birdshot retinochoroidopathy, which we don't have in our setting. So polymerase chain reaction, the commonest test that comes to your mind when you think of laboratory tests, the PCRs. So we use it for various forms where you have a clinical suspicion of virus uveitis, any variant of viral uveitis, tuberculosis, ocular toxoplasmosis, and it has also been now used to detect the rubella virus and the CMV in patients with Fuchs uveitis. We have more advanced forms of PCR in the form of quantitative, real-time, multiplex and multi-targeted. Multi-targeted means you are targeting more than one gene of the same organism. Multiplex, you are targeting more than one organism on the same panel. So multi-targeted PCR has been used by us in uveitis and especially tubercular uveitis, utilizing 2 or more targets for MTB. The idea is to improve the overall sensitivity. It increases the yield of detection from the ocular samples, and its rapidity and ease of performance is an excellent alternative, but in relevant settings if you have the facility. Now, the latest that we have seen is the multiplex strip PCR test for infectious uveitis, and this is the team from Japan, which is recently published in the AGO. This was a prospective multi-center study. where they used a novel multiplex PCR strip, which is also known as the strip PCR, for 24 common ocular infectious disease pathogens, which included various forms of viral pathogens, syphilis, toxo, etc. And they compared this strip to conventional quantitative real-time PCR. They detected the pathogen DNA at concentrations varying across a very wide range from very low to very high. The strip PCR showed a very low intra and inter-institutional variability even when it was performed by the technicians with various PCR skill levels. The strip PCR results correlated with the quantitative PCR data. The correlation was quite high, 0.838. So the authors recommended that the easy-to-use strip PCR can be used for rapid diagnosis of infectious uveitis. Above that, there is a direct strip PCR test. Now this skips the DNA extraction step in the procedure. I will not go into the details of the DNA extraction and the PCR steps, but one advantage is that that step is eliminated by using this direct strip method for PCR. This is anticipated to ease the etiological evaluation, increase the pathogen detection in the intraocular fluids of uveitis patients, even by general ophthalmologists. The goal is rapid and simple comprehensive PCR diagnosis anywhere and by anyone, even with not really good technical skills for ocular infections. You've heard about GeneXpert MTB RIF assay. The GeneXpert was recommended by the WHO in 2010 as a rapid automated nucleic acid amplification assay, which is used widely for simultaneous detection of MTB complex as well as rifampicin resistance in no time in various specimens. First it was approved in sputum specimens for pulmonary TB, and now it is widely recommended for extrapulmonary TB. We have a good experience of this test in uveitis in intraocular fluid samples. The GeneXpert detects bacilli. For it to detect the bacilli, you need to have 131 bacilli per ml, and now we have the GeneXpert Ultra, which is much more sensitive, and it can detect 16 bacilli per ml of the fluid sample, whatever it is. Coming to the primary intraocular lymphoma, any patient with a suspected primary intraocular lymphoma, before we go into the eye, it's a good idea to order the MRI in contrast enhanced for the patient to rule out or to rule in any neurological involvement. Then we go ahead with the diagnostic vitrectomy and spinal tap and the following of each strongly are supportive of the diagnosis. Now, it's histology or cytology. We send the intraocular fluid to the cytologist for detection of the lymphoma cells and for grading of the lymphoma. CD19, CD20 and CD22 immunopositivity with restricted expression of either kappa or lambda light chains. Flow cytometry is used to detect the interleukin IL-10 and 6, and the ratio of IL-10 is to 6 is more than 1 is important for diagnosing lymphoma. Molecular analysis includes the mutations in the MYD88 gene using the droplet digital PCR, and once we are then done with these tests, PET-CT for involvement if you're suspecting beyond brain or eyes. IL-6, just a word about it. We know it's a pro-inflammatory cytokine implicated in various immune-mediated diseases, including uveitis. It is produced by the monocytes, macrophages, B cells, and T cells. In particular, it is involved in differentiation of CD4 cells into Th17 cells, which have been shown to play a very significant role in immune-mediated diseases, including uveitis. So IL-6 is a pro-inflammatory cytokine. IL-10 plays major anti-inflammatory and anti-angiogenic roles in most of the ocular inflammations. Now, many studies have decided a cutoff for IL-10 when you find this in the aqueous or the vitreous humor. So a cutoff of 65 picograms per ml and 30 of IL-10 in the vitreous and aqueous humor respectively was associated with a good sensitivity and again a good specificity. And if you look at the ratio of IL-10 is to IL-6, more than 1 of this ratio in the vitreous had a very good sensitivity and 100% specificity. Now, MYD88 mutation, myeloid differentiation primary resource 88 or the MYD88 gene is located in the chromosome 3p22.2, and it provides instructions for making the MYD88 protein involved in signaling within immune cells. The activation of this MYD88 leads to increased downstream pro-inflammatory and favors tumor cell survival. A single base change in the DNA sequence in this gene resulting in a specific amino acid mutation at position 265 leads to constitutive activation of the B cells, and it is associated with various disease states. So the diagnostic utility of MYD88 L265P mutation is superior to the conventional cytological analysis in case of primary vitreoretinal lymphoma. And this analysis of this MYD88 gene is very important, and it's very reliable and efficient for diagnosing intraocular lymphoma. Cytology, as I said, for any case where you're suspecting primary intraocular lymphoma or masquerades or malignancy. Vitamin D is another upcoming topic, the investigation in patients with ocular inflammation. There is a growing body of evidence linking the two, and hypovitaminosis D has been associated with ocular sarcoidosis, JIA-associated uveitis, BKH and HLA-B27 uveitis. So it's a good idea to order this test in some of the patients. You may not have a very conclusive evidence or a definitive information, but yes, you can at least see the underlying status of the patient.
Dr. Rima, please. Invite.
I think I'm done almost. Cytokines in uveitis, I've talked about the two main, IL-6 and IL-10. So they are increased not only in, they show not only a local expression, but also in various systemic diseases also. And CD4, CD8 ratio in ocular fluids for sarcoidosis is important. So I'll not touch upon the imaging because we have a subsequent talk by Dr. Sima who will be talking what's new in retinal imaging. So enhanced depth imaging, just a word about it, has been used for quantitative analysis of the choroid and to look for choroidal thickness and choroidal vascularity index in many types of uveitis, and of course OCT angiography for detecting inflammatory choroidal neovascular membrane. So to conclude, the newer diagnostics in uveitis have a limited role in day-to-day diagnosis and management of patients. Their cost is another issue, and you need to be targeting them depending upon the setting, whether you are in a government or an institution or a private practice. Of course, they are more suitable for research settings with the resources. So, but they do play an important role in cases which pose a diagnostic and a therapeutic challenge. Thank you very much.
Thank you, Dr. Rima, for a very lucid talk, and I'm sure everybody is benefited. Meanwhile, when you can ask questions from Dr. Rima, I think I'll request Dr. Simar to please come for the thing. Any questions for Dr. Rima? Okay, thank you, Dr. Rima then. अमृतसर से हूँ रिपोर्ट्स नहीं हुए उनको बेसिक ही नहीं पता मैंने मेलानोमा पढ़ा दिया उनको बेसिक मेलानोमा तो न्यू फोल्डर पढ़ा दिया उनसे सेल्फ लेयर कैरेटिक प्रेसिपिटेट्स बताते थे they were last.
Thanks to Dr. Suresh for this opportunity to present here. In the meanwhile, while the presentation is being set up, can I know what all medical colleges are represented here with us except GMCH 32? And what all retinal imaging modalities have you actually seen being done at your medical college? We can start from this side. Can you just speak out loud your medical college? DMC Ludhiana. What all medical retinal imaging modalities have you actually seen being performed at your institute? OCT, photography, angiography, OCT, angiography. Anybody else from back there? What all retinal imaging modalities have you seen at your medical college? OCT. Anybody else other than OCT? Anything else you have seen? Autofluorescence, anybody? Which one? Right. So basically what I am going to do in these 10 minutes is introduce a lot of terms to you. It's very difficult to go into the details of all these imaging modalities in 10 minutes. Each can be a half-an-hour lecture. So, at least you should know that these things are available and how they can be used in various retinal diseases. So these are basically the broad topics that we are going to cover. Color photography, I think majority of you would have seen and is the basic thing that is done. So there is nothing new in this, but still this is the best way to image the retina. and you get a true color image of what you are seeing in the pathology clinically. We have moved on from analog models to digital models and have widened our field a little bit. Smartphone technology has come in a big way into this, and this technology has been miniaturized from what it used to be earlier. So a lot of these devices for telemedicine are now being used new, and also self-screening devices are being made with the help of color fundus photography, where a patient can click a picture of his own retina and sometimes even do an OCT on his own retina and send it to his doctor and monitor himself for the disease pathology such as diabetic macular edema. So moving on to the next, that is SLO based imaging. I think this is the new thing in fundus photography, where instead of the normal light source that you are using, you use a laser source. So with the laser, what is the good thing is that you are using a targeted wavelength. So you get a very high resolution image, and you can even image through media opacities. So lasers perform imaging at multiple levels and then collate all those images to give you a single image. So that is a very high resolution image. The disadvantage is you don't get true colors. They are pseudo colors, and you can use only one form of laser at a time. So this is a typical multicolor image that you get on the Spectralis, where 3 lasers are used. One is in the infrared spectrum, one is in the green spectrum, and one is in the blue spectrum. And this is the composite image that you get. So each of these give you better details of pathologies at different levels of the retina, such as the infrared will give you more details about deeper pathologies, maybe in the choroid, and the green reflectance will give you better details of what is on the surface of the retina, such as epiretinal membrane. And you can see very clearly here, this is a true color image, and this is a multicolor image of the same, and the same epiretinal membrane is much well delineated over here. So this is something new that we have in fundus photography. Then the ultra wide field imaging, I think, has come in a big way over the last 5 to 6 years. So we can image almost up to the ora serrata in a single shot rather than the traditional imaging. So this is what we get with a standard fundus image, where this is about 30 degrees of view. You can see some hard exudates, you can see some hemorrhages over there, but you don't really know what is going on. But if you go on to the wide field image, this is a 200-degree image, and you can see the same pathology. You see a totally different pathology. You may be thinking diabetes earlier, but now what you are seeing is actually what we call as PEHCR, peripheral exudative hemorrhagic chorioretinopathy. So this gives you a much better view. And in this, we have contact-based systems also for pediatric retinal imaging, such as the RETCAM and the Forest Trinetra Neo, which give us about up to 130 degrees of view in true color. So coming on to autofluorescence, I think if out of all the newer modalities, if anything has added more to our armamentarium is autofluorescence in managing the patient. So autofluorescence basically takes use of the natural light fluorophores that are there in the retina, mainly the liposuction, which is a byproduct of the vision cycle, and we give a particular wavelength of light which excites this lipofuscin, and we can then take the fluorescence out of that and get an image. So this is the traditional fundus camera where we use a wavelength range and get the autofluorescence. This is with a SLO based system where a particular single wavelength is given, and hence you get a very good resolution autofluorescence. This is a short wavelength or the blue autofluorescence that you say. And this is on the wide field Optos imaging system, which gives you a green autofluorescence, again a short wavelength, but a green autofluorescence. So you can see there is a little difference, but again we are exciting lipofuscin in all of them. So something called as near infrared autofluorescence also that has come in now, which is in the Spectralis SLO based systems. So the difference there is that they excite the melanin pigment instead of the lipofuscin. That is still being investigated, that probably that may have a better role in some of the disease pathologies in giving you this. So autofluorescence is very useful in monitoring patients, how they are progressing, how that area of atrophy, of how the area of the disease inflection is progressing, and whether there is new activity coming up in a disease or not. Coming on to the next, OCT, I think which most of you would have experience with, would have seen. But some of the newer things that have come in now, we have moved on from the era of time domain OCT to spectral domain OCT, and swept source, a type of spectral domain which gives us further deeper imaging in the retina. And newer OCT nomenclature of the retinal layers, all of you should be knowing. It's 5 years since this has come in. So you should, almost the histopathological correlation we can do on OCT, and you should be knowing each of the layers, that which hyperreflective layer corresponds to which anatomical layer of the retina. EDI OCT, as Dr. Rima was talking about earlier, in the uveitic pathologies, also in some retinal pathologies like PCV, where you want to image the choroid. So it gives you enhanced depth to image the deeper structures. And this scan, while most of you might think that this is a fundus photograph, but this is actually a OCT scan. So this is an en-face OCT scan, a newer kind of concept. It was always there, but this is something that we have started using more. So basically, you are seeing the retina as a slab of the whole OCT. So normally we are used to seeing these cross-sectional scans. This is just a slab of this seen from the top. So that is an en-face OCT scan. Also now we have intraoperative OCT and handheld OCTs for pediatric patients. Also OCTs mounted on a microscope arm, which can be done for supine patients as well as pediatric patients under general anesthesia. So these are some of the newer things you should know. Also a lot of newer OCT terminologies have come in. Some were mentioned by Professor Vishali also, like drill and the hyperreflective spots. It's good to know what they mean. They have some implications, but at your level you should at least know the full forms. You should know certain implications of these terminologies. You may not remember all of them, but yes, I have just put in, this is not a comprehensive list, just put in some of them. I hope you know some of these full forms, but you should read up about them. There are a lot of literature about it. And these are all based on analysis of the OCT scans. Coming on to OCT angiography, again, this is something not, the hardware is not new. It is the same OCT scan that we were taking earlier, but it is the software that has come up that we are taking out more information out of that OCT scan. So OCT scan, multiple OCT scans are passed from the same location, and they check the signal of each OCT scan. And any point that is showing a variation, they assume that that is because of flow of blood through that area, flow of RBCs through that area, because the reflectance of each scan changes, and that is assumed to be a blood vessel and marked as a blood vessel. So when you composite it over a particular area, you get the whole en-face OCT angio scan that we are most commonly looking at. So this is the structural B scan, and along with the flow scan, which actually gives you which areas have flow. So all these red dots and the pink dots that you are seeing, these are color-coded flow scans. And you can see this area of hyperreflectivity on the OCT. We don't really know what it is, but once you do an OCT angio, you see that there is too much of red over there, so there is flow going on over there. And on the en-face scan in the outer retina, you see that there is a choroidal neovascular membrane, or a macular neovascular membrane, as the newer terminology may suggest. So again, you can monitor these neovascular membranes as they grow or regress on the OCT angio scans. But this do have a lot of artifacts. We don't see any leakage. We can't base our focal laser treatments based on this. So there are some disadvantages as per the against the dye-based angiography, but it has brought in a lot more into an armamentarium. Coming on to the dye-based angiography, the traditional angiography that we always used to be doing, this is a patient of CSR. You can see the fluorescent angiography showing you a typical smokestack leak. So that has always been there. So something new that has come in is the, again with the SLO-based systems, we can do fluorescent as well as ICG angiography at the same time and acquire them at the same time. So this you can see in a patient of PCV, you can very clearly see these polyps on the ICG, whereas you don't see much on the fluorescent angiogram along with the branching vascular network. And again with the Optos wide field, you can acquire the same images for a wide field up to 200 degrees on the ICG also, along with the fluorescent angiogram. So this was the patient of peripheral exudative or peripheral PCV that I showed, and you can see these polyps that can be seen in the periphery in this patient on ICG angiography. So coming on to some of the newer modalities which are still under the research phase as of now, adaptive optics. Again, there is not much of new hardware in this. This is basically the same SLO-based scans that we are doing, but basically our eye abrasions, higher order abrasions, don't allow for high resolution imaging of the posterior segment.
Adaptive optics kind of adapts the optics in such a way that those higher order aberrations are negated and we get very good high resolution images. But anything when you go higher on resolution, your field of view keeps on decreasing. So here you can see these small boxes that are there actually of this image, and in just one of these boxes you can actually see each of the photoreceptors over there on this scanning. But the field of view is very much restricted. So as of now it is more of a research tool and has less utility in clinical practice, but this is something, some of the names that we should be knowing. Coming on to FLIO, that is the latest, that is Fluorescence Lifetime Imaging Ophthalmology. Again, it is a software-based tool, not a hardware. It is based on the fundus autofluorescence that we already talked about. So it is a derivative of that. Instead of measuring the instead of seeing how much autofluorescence is there, we are seeing how much time that pigment is fluorescing for once we excite it with a certain wavelength of light. So that gives us an idea about the health of the retinal cells, health of the RPE as to how good it is. So the longer the time, the darker the color. And you can see this is the normal, and in a macular hole you can see that this is not there. And in albinism again, because there are lesser number of cells, you can see that the fovea is not well developed. You can see that loss over there. So in some diseases like dry AMD, you can monitor the health of the retina and predict visual loss before it actually happens and try and preempt it. The last is the image analysis. A lot of image analysis we already talked about. OCT, angio, FLIO, adaptive optics, all are based on image analysis. But also the quantitative image analysis, be it the B-scan Ma'am was talking about, the choroidal vascularity index, again it is based on an image analysis of the EDI OCT that we have gotten, that to how much vasculature is there and how it is changing with time. Again, we can do it with OCT angiography, we can do it with fundus autofluorescence. So these things are coming up in a big way. Artificial intelligence models are being created based on this to predict how the course of the disease is going and if the patient is going to develop disease. So this is still not the standard of care, but this is the future of our imaging as we are going towards personalized imaging, as we already heard. So take home points, retinal imaging is rapidly evolving. We need to keep abreast with some of this latest technology and also acquire some of them because they are going to be essential in our managed practice. Multimodal imaging, not one form of imaging is not the answer. When you put these all together, they give you the best answer to the disease pathology. And the future lies with artificial intelligence assisted diagnostics rather than artificial intelligence taking over us. Thank you so much.
Thank you, Dr. Sima, for a wonderful, wonderful thing, which is need of the hour. I think each one of us, like he said, must be at least, you must read about all these terminologies which are talked about. And it's very difficult to cover in 10 minutes, but you covered it beautifully, I would say. Thank you, Dr. Sima. Any questions for him? Now we can pass on to cornea session. Dr. Arun Jain, I see here. Dr. Suresh.
Good afternoon, everyone. We welcome you all in this cornea session. Just for our knowledge.
Light nahi na aati koi. Okay.
How many students of all of you are from third year PG? Second year? First year? So mostly second year students.
At how many places the keratoplasty is being done? Raise hands. So maybe how many? Raise little.
All of you from GMCH?
No, apart from GMCH, other colleges where keratoplasty is being done, from where you have come.
AIIMS Rishikesh.
Okay. Niti is there, yeah. So basically, this section is on lamellar keratoplasty. Way back 3 decades ago, mainly it was a penetrating keratoplasty. So at how many centers, just for the knowledge sake, how many centers are doing lamellar keratoplasty in form of a deep anterior, DLAC, DSEC or DMAC? Have you people assisted? How many of you have assisted penetrating keratoplasty? Or, okay. How many of you have done therapeutic keratoplasty? Not, okay. JRs, okay. Anyone who have assisted these lamellar, any one of these DSEC, DMAC or deep anterior lamellar or partial anterior lamellar or DLAC, deep lamellar endothelial keratoplasty?
I think maybe due to COVID, surgeries are not being done nowadays.
So it is just a primer because it's too short, 1 hour is too short a time to, have a didactic course on covering all these types of keratoplasties. So first I'll request Dr. Chintan Malhotra, who is professor at Advanced Eye Center PGI. She will just prime you with the idea of lamellar keratoplasty and when to do what type of lamellar keratoplasty. Professor Chintan Malhotra.
Thank you, sir. Very good morning to all of you. Nice to see young, bright faces here. As we've said, it's not possible to cover the detailed thing. The aim of my talk is just to make you familiar with the terminologies. There is an exponential increase in the terminologies which are used in lamellar keratoplasty, but the basic principles remain the same, and this can be basically clubbed into 2 or 3 categories of the keratoplasties which are to be done, right? So once we are talking of lamellar keratoplasties, we need to know that the cornea has layers. We could call them components, or for the purpose of lamellar keratoplasty, cornea has lamellae. So basically there are 6 layers. We are familiar with the 5, which is the epithelium, the Bowman's, the stroma, the Descemet's membrane, and the endothelium. A new layer was discovered, or at least it's been by Dr. Dua, which was described as a Dua's layer or the pre-Descemet's layer, which is supposed to be between the posterior stroma and the Descemet membrane. There is some controversy about whether this is actually an anatomical layer or not, but from the functional point of view, as we'll see in DALC and DSEC and DMEC, this layer does exist. This is a tough layer between the posterior stroma as well as the Descemet's membrane, right? Now coming to the terminology, we have anterior lamellar keratoplasty, which is basically for disorders of the Bowman's membrane and the stroma. And we have the posterior lamellar or the endothelial keratoplasties, which are for endothelial disorders. Anterior lamellar can further be divided into what is known as a SALC or a superficial anterior lamellar keratoplasty, where the pathology lies mainly in the anterior 150 to 160 micron of the cornea. You have an automated lamellar therapeutic keratoplasty where things are done in an automated manner and we go a little deeper up to 200 to 350 microns. And then we have a deep anterior lamellar keratoplasty, which is known as a DALC, the most common indication for which is keratoconus. I'll come to other indications later. DALC basically involves removal of 90% of the stroma to 100% of the stroma. So it is divided depending on the technique in which it is done to a pre-descemetic DALC, which means that you remove 90% of the stroma, 10% of the stroma, and the descemet and the endothelium remains behind on the recipient eye. And the D-DALC is a complete bearing of the descemet membrane, that there is no stroma. You directly have the descemet membrane, on that the endothelium is there. And then we have the endothelial keratoplasties, basically where for endothelial disorders, where we have a Descemet stripping endothelial keratoplasty, which if it is done manually, it is known as a DSEC, and if it is done in an automated manner, it is known as a DSAEK, A standing for automated. Then we have the DMEC and the PDEC. I'll just show you in the next slide. So the conventional was the penetrating keratoplasty, where we are removing the whole cornea and replacing the whole cornea. Then we have the DALC, which further can be kind of divided into a SALC, the superficial anterior, where you remove anterior 30 to 50% stroma, or the deeper, which is the classic DALC. And then for the endothelial keratoplasties, we have the DSEC, the Descemet membrane endothelial keratoplasty, and the PDEC. In all of these, the Descemet membrane and the endothelium is replaced because that is the diseased tissue. In DSEC, there is a component of posterior stroma also. So it is a thicker lenticule, and that can range between 70 to 200 micron, depending on the technique of DSEC. DMEC has no stroma, it is just the Descemet membrane and the endothelium. And PDEC is something where you have the, what I mentioned, the Duas layer, which is the 15 to 20 micron thick Duas layer, that plus the Descemet membrane plus the endothelium. We'll come to the advantages of each of these a little later. And there are also terminologies, once we call it, if everything is done manually, it's a manual procedure. If both the donor and the host are operated upon using these automated keratomes, then it's automated. And there is a term known as, we'll come across a term known as HALK, hemi-automated lamellar keratoplasty, where on the donor cornea you use a keratome and the host cornea, that is the recipient cornea, is dissected manually, right? So now, why the need for component surgery? Just briefly, I'm sure it will be covered in the further talks also, because penetrating keratoplasty has its drawbacks. There it's a full thickness wound which never completely heals. It's an open sky procedure, so risk of intraoperative complications like expulsive choroidal hemorrhage. There is a higher risk of rejection and graft failure. Even with trivial trauma, there can be graft dehiscence, and there are also suture-related issues. And more importantly also, there is a shortage of donor tissue. So there is a gross mismatch between availability of the corneal tissue and the number of patients who need it. And this is where lamellar surgeries effectively address many of these problems. The endothelial keratoplasties are essentially suture-free, so you don't have suture-related problems, whether it's infection or it's, the other astigmatism. Visual recovery is faster, and the tectonic strength of the globe is preserved. DALK has sutures, but the sutures can be removed much earlier, so that's an advantage. And more important, what Professor Jain will be covering in the next talk is that a single tissue can be used for more than one recipient. For example, if you have a patient who needs a DALK, so use the anterior part of the cornea for that, and simultaneously Descemet membrane and endothelium can be harvested, and the patient can undergo a DMEC. So from one tissue, you could use, probably, you do 2 patients, or sometimes even more. So that brings us to the main part of this talk, when to do what. It's just important to know for what indication which procedure is made. So anterior lamellar keratoplasties, it is just one gross principle we need to remember, that we do it in conditions with stromal pathology, but the endothelial function of the patient is adequate, because that is what is going to maintain the graft in a clear form. So for example, you have keratoconus, where the whole of the stroma per se is involved, or a keratoglobus or a pellucid marginal degeneration. There one can go in for a deep anterior lamellar keratoplasty. If you have stromal dystrophies, depending on the level of this dystrophy, granular, macular, lattice, whether they involve the superficial part or deeper parts also, one can go in for a SALK or an anterior lamellar therapeutic keratoplasty. And also corneal opacities. So we have one of the most common causes in India is corneal scars post-infection or following thermal and chemical burns. Here we have to remember that in case we have to do a DALK, then the Descemet membrane should be spared. If the Descemet membrane is involved by the opacity, then we cannot go in for a lamellar keratoplasty because your interface will not be clear. And contraindications intuitively are conditions where the endothelium is dysfunctional, because we are not replacing the endothelium. So a patient who has a pseudophakic bullous keratopathy or any endothelial dystrophies, for example, a Fuchs endothelial dystrophy, a congenital hereditary endothelial dystrophy, these are not patients who would require a anterior lamellar keratoplasty. They would require an endothelial keratoplasty. So this is just an example, a classic indication. This was a 9-year-old girl and her brother both who came with granular dystrophy. And we can see that the ASOC is nicely showing the lesions are limited to only around 120 microns of the stroma. Some are deeper. And here we decided to go ahead with a anterior lamellar therapeutic keratoplasty. So just we went because it depends on the availability of the heads. You have different heads, the depth we have. I wanted to go in for an automated procedure. We have a 200 micron head. So we went in for what is known as an automated lamellar therapeutic keratoplasty. So you mount the donor cornea onto the keratome. This is the Moria ALTK system. And the anterior cap, this anterior cap that we get is the one which is transplanted onto the patient's cornea. Now this is the patient's eye. Again, the suction ring is applied. And we then cut the anterior cap. I will just pass forward it a little. Right? So we cut the anterior part of the patient's stroma. We remove the disease pathology. And then one measures the appropriate size and one just replaces this anterior cap that we had got. So this is a form of an anterior lamellar keratoplasty. The terminology would depend on the depth to which you have got. So this is how the interface appears clear, and the interface is very smooth in these cases, the automated lamella, and the patient can get good vision, and you can see the interface appear very clear in the lower half. Now, there are some challenges with ALTK. There is difficulty in working on an intact globe, and the exact sizing may be a problem, but those are issues which can be taken care of. The graft lenticule is always prepared before the recipient to ensure a proper sized disc before we touch the patient's eye. We don't want to touch the patient's eye and then not get a good graft, right? This is just another video to show that the same thing can be done manually. So this is on the donor eye now. We are using a guarded depth trephine instead of the microkeratome, and this can be dissected manually using your crescent knife and your lamellar dissectors. Right? So this is the manual dissection where you use a combination of scissors as well as your lamellar dissectors to dissect. We've dissected this and then are using scissors. And similarly, for the donor as well, one can just use a guarded depth knife and you can dissect this manually. So here both the donor as well as the host are dissected manually, and then you can place the cap, and the rest of the procedure is similar. The only disadvantage with the manual procedure is that sometimes the interface is not so smooth as it would be with an anterior lamellar, but one can get a decent outcome with this. So that is basically the principle of the anterior lamellar keratoplasties. Stromal pathologies not involving the Descemet membrane and the endothelium, one tends to go in for anterior lamellar keratoplasties. The second half is the endothelial keratoplasties or the posterior lamellar keratoplasty, where you have pathologies which are related to the endothelium, which I have already mentioned, Fuchs endothelial dystrophy, ICE cells, or other conditions which I will come to later. So the indications are endothelial dysfunction or corneal edema without visually significant stromal scarring. Now this is important because if you have stromal scarring, here you are not replacing the stroma, you are just replacing the endothelium and the Descemet's membrane basically. So you need to have a good clear stroma which then your replaced endothelium can detergent and make it clear. So the indications would be all causes of endothelial decompensation, a phakic or pseudophakic bullous keratopathy, you have Fuchs or congenital hereditary endothelial dystrophy. Failed keratoplasties are nowadays becoming a very strong indication. So if you have one failed keratoplasty, instead of repeating a penetrating keratoplasty, one can go in for an endothelial keratoplasty, right? And then you have the other causes. Endothelial decompensation may be caused by a toxic anterior segment syndrome or recurrent uveitis. Any condition which causes endothelial pathology, you would go in for an endothelial keratoplasty. In all these procedures, DSEC, DSAEK, DMEC, the basic principle, I'm sure Professor Arya will be showing some videos of this, is that you remove the diseased host, you remove the endothelium by stripping and scoring. Some of you are doing it in the wet lab also. So you remove the diseased tissue from the patient's eye, and then you replace it by the tissue whichever you are replacing it with. In DSEC, this tissue would involve the posterior stroma plus the Descemet membrane plus the endothelium, and this is just one of these pictures. Busenglide is one of the ways in which this tissue can be implanted into the eye. And this is, you can see how good the results are. A patient with pseudophakic bullous keratopathy, and the cornea becomes very clear. Takes, depending on how much the surgical trauma is and how good your graft was, ranging from 1 month to 3 to 4 months, and the graft clears up very nicely. Then just a small video about DMEC. So in DSEC, I'm sure the videos will be there later on. In DMEC, basically we are replacing only the endothelium and the Descemet membrane. So this is the Descemet membrane being peeled off, Descemet membrane and the endothelium being peeled off. Then you kind of, this is floated back. And also we need to know which side goes in. We have to have the proper orientation of it, right? Trypan blue is useful. You use that to stain. And then it tends to, this is how it tends to curl up. Because of the elasticity of the Descemet's membrane, this tends to curl up, and with the endothelium on the outer side. You then inject it into the patient's eye. So this is a very thin tissue as compared to DSEC. And then the donor is inserted, and various techniques which perhaps you don't need to know at this level are used. Basically an air bubble is used to stick the graft in place, right? So this is how a DMEC differs from a DSEC. There is no stromal tissue. DMEC has various advantages over DSEC because it has a better visual recovery. Since there is very thin tissue involved, there is minimal refractive error, and there is also lesser incidence of rejection because you are using less of the foreign tissue. It's a thinner tissue, so less foreign tissue is there. And more patients achieve a better visual acuity. But there are significant challenges with DMEC, not so much into detail. Basically, wherever in the eye you cannot retain air to hold the graft up, for example, eyes which have a large peripheral defect, large iris defect, or eyes which have glaucoma filters, for example, tubes, there that graft will not remain so well. It may even flow out of the opening in the eye, which is the shunt, right? So in these cases, I'll just be brief about this. These are the cases where you would choose DSEC over DMEC. So eyes having large filters, glaucoma shunts, large iris defects, iridocorneal endothelial syndrome, all these complicated scenarios, DSEC would perhaps be better than DMEC. Otherwise, for most conditions, wherever your endothelium is defective, DSEC and DMEC are interchangeable. You just need to know that if the endothelium is defective and the stroma is clear, one can go in for an endothelial keratoplasty. PDEC I already mentioned, it includes part of the Duas layer, so it is a little easier to handle than the DMEC tissue, but it's not as popular. There are people doing it, but DSEC and DMEC are the classical surgeries which are usually done. The other thing which needs to be taken care of with the DMEC is the donor should not be very young. If the donor is very young, then the tissue tends to curl up too tightly and it is difficult to unfold in the eye. So that is one limitation with the DSEC. So that was, I think I'll finish there, just to know that we need to know that we can classify it into anterior and posterior. Anterior for stromal pathologies, you decide on the level of the pathology, and posterior where you have the endothelial dysfunction, right? Thank you.
Thank you, Dr. Chintan, for very wonderful talk. You classified all lamellar surgery in a very clear-cut way, which are the layers in which type of surgeries, and with good videos you demonstrated everything. Any question from the students?
Anything which is not clear you want to clarify?
So that was very basic.
Just to understand the concept of lamellar keratoplasty. Yes, you have a question? No.
Or I invite Dr. Arun Jain, Professor, PGI Chandigarh, again heading cornea and effective surgery unit in PGI Chandigarh. So he's going to speak on split one donor cornea for multiple recipients. So again, very good, very nice concept. Like one cornea can be used for many patients. So what is that concept? So he's going to clarify about that. Dr. Arun Jain, please.
Thank you, Dr. Arya.
वीडियो बहुत अच्छी थी, क्वालिटी।
So Dr. Chintan has already highlighted different types of keratoplasty.
मैंने जो बोला था आपने सारा होस्ट बोल दिया।
हाँ,
दो चार चीजें बोलो।
डी में कभी मैं जल्दी स्किप कर रही हूँ।
Yeah. Yes.
लैपटॉप चेंज किया, सेम लैपटॉप चेंज किया ना?
Not able to understand because I kind of skipped through the last slides because it will be covered in the next talks.
Sorry for little glitch. Sorry for little technical glitch. So, as Professor Chintan has already highlighted the indications, nomenclature, and contraindications for doing different types of lamellar keratoplasty, and she has shown you the short procedural videos also. Most of the instrumentation for automated lamellar keratoplasty is quite expensive, but you can do all these things manually also, for which you don't need any heavy investment in the equipment. Just you have artificial disposable chambers also available, where you can dissect the cornea into anterior lamella and posterior lamella. That is what is called manual Descemet stripping endothelial keratoplasty. DMAC is purely a manual technique. There is no need of any instrumentation. It is only the expertise you do in the lab to separate. So same way we can use a single eye, especially during last 2 years because of COVID. The eye donation has gone down drastically. So there was hardly any donor tissue available. In such times, if we can use one cornea for multiple patients, like for anterior lamellar and DSEC, or dark and DMAC, so it sort of serves the purpose of shortage of corneal tissue demand. So I'm going to show one such, maybe split cornea. Same cornea, same eye can be used for multiple patients also. You can use anterior and posterior part, limbal part can be used for, if the eye is stretched, it can be used for limbal stem cell transplantation. So there are multiple, and sclera can be used for various backdraft or for shunts and all those. So we shall not let the tissue go waste. Okay, so I have no financial interest in the subject matter of this talk. So for last 3 decades we are hearing that so many people are bilaterally blind in India who needs keratoplasty, and to this 20,000 are added per year, and we have a collection of 40 to 50,000 cornea annually, and but the annual requirement is much more than that. But this is a very old figure, and recently a survey was conducted in India by the AIMS, and which shows that the corneal blindness is much more as compared to the previous figures given. It is next to the cataract blindness. It is to the tune of 8.2%. That is shown graphically in this various reasons. So this is in plus 50 years of age. And if we go to less than 50 years of age, you can say the corneal metastasis leads to blindness in more than almost 40% of the cases. So it is for you young people to know that the demand for cornea is much more than what is projected earlier. This is a recent survey in 2018-19. So this is the major cause of next to cataract surgery, the corneal blindness, which is again shown graphically in this pie diagram. So these are already highlighted by Dr. Chintan, and this concept of split cornea was introduced way back in 2007 by Dr. Vajpayee, and this is not a new concept. Various publications are there in literature since last 1 decade, which shows that the demand of the cornea can be reduced by almost 40% if we use split corneal tissue. So as this is also already discussed, we can split cornea into anterior lamella, posterior lamella, DMAC or dark, and use the same one cornea for 2 patients. So, so this is another patient where they use 100 consecutive corneas for one cornea for 2 patients, and they projected that it can reduce the demand on the corneal tissue, and they said that they can preserve the cornea even separately enough for 1 week to be viable, so that you can plan your surgery, because sometimes there is a logistic problem. You may have cornea, but you may not have 2 patients who require that type of keratoplasty. So once you can store it for a week, you can plan the keratoplasty. It is no more an emergency procedure, it can be planned. So now she has shown you the automatic, I will show you the manual. This is the automatic lamellar keratoplasty chamber, but any disposable chambers are also available which can be used. And here I will, you can have a guided trephine so that you can dissect the anterior lamellar tissue. So this is a guided thing where we can plan the depth of the cornea to which it can be dissected. There are guarded ones, and here I am doing the manual dissection of the anterior lamellae. It's not a dark, it's a sort of a deep, not a descent sparing keratoplasty, but it is a, so we split the, we will going to do anterior lamellar as well as manual dissect in this case. Once we have done the lamellar dissection, we invert the graft and do the punching. So this is one patient with the anterior granular dystrophy. I will show it again. And the anterior part of the lamella is shifted to the suture to the corneal bed, because mainly in this case the granular dystrophy was limited to the anterior one of the cornea. So once you suture that with the either interrupted suture, or you can so this is the patient. So you have to know the area of the cornea involved. After that you do a central marking is done, and this is on the recipient. Again a guarded trephine. So you can again not doing a automated. So again these disposable trephines are available, because ALDK system again is quite expensive. It may cost around 65 lakhs plus, but you can do it with the ordinary available guarded trephine. So once you do a manual dissection, right, and it is very easy. It is a sort of people do it even in the cyclodialysis spatula. Once you get into a proper plane, it's very easy to dissect. And once you have dissected that, you shift the anterior lamella. So this is what we have dissected and put it there. So as Dr. Chindan highlighted, with the automated keratoplasty, it's sometimes very difficult to match the donor and the recipient size, which is not a problem with the manual dissection. Here you can exactly get, because in automated it's sometimes difficult to get the exact size. So to overcome that problem, you have to cut the donor to maximum diameter, and then you have to punch it again according to the what you get in the recipient, this thing. So this is after continuous suturing, and this is what you see. This is pre-op patient. Patient had already, this is a patient had already undergone once a keratoplasty. You can see the in other eye there is a very high astigmatism in this eye. And this is the left eye of the patient. This is done at Hyderabad, and this is the lamellar keratoplasty, and patient had very good vision with the minimal astigmatism. And the deeper part of this corneal button we use for manual descent. So this is a bullous keratopathic patient. So I'll just the epithelium is loose, so you remove the epithelium and just fast forward it, and then you make a superior 5 mm tunnel from where you have to inject the folded graft. So once you make a tunnel, you mark the cornea 8 millimeter, and through the side port, if you are not sure initially to begin, you can stain the Descemet's membrane or endothelium, so that it is, I am staining the endothelium, so then it becomes easy, and then once you have stained it, you wash it off, and this is a Descemet's scorer. So you score the 8 millimeter area of the Descemet. It is descemetorhexis. It is just like what you do capsulorhexis. Once you have scored it, and with the scraper, you just scrape I'm completely in the circle from the inferior end. So it's a thick and membrane. You should not be going too deep in it. So this is Descemet's scraper. So you pull it out, scrape the Descemet. You can see it's quite thickened. So once you make sure it is full is taken out. So it's a full disc of Descemet. After that, what you do is, this is the deeper part of the button. So there are various ways of putting this button into the anterior chamber, like she showed a Descemet inserter. You can push it manually. This is a Busenfly. So, but the button was a little thick, so I just used the Ogawa forceps. There's a special forceps with a gap in it. So first I tried, but then I thought the graft is a little thicker. This is just to mark the orientation of the graft. Many people will put F, S, or it all depends on your convenience. So this is the Ogawa forceps. So you can see there is a platform here and there is a gap here, so that there is no crushing of the endothelium. So you fold it 60-40, so that once it is inside the chamber, you can unfold it easily. Because if it is 50-50 folded, it is difficult to unfold. So this is injected into this anterior chamber and maybe gentle nudge there. Usually one should use an air bubble. Now with the air bubble, I will open it and then center it. So you inject the air bubble, and from the other side, in DMET you have to make only 2 millimeter incision, because and after injecting this thing, the graft, you have to suture it. Otherwise, even in this case, one should suture it, but it is a self-sealing this thing. So you maintain this here for almost 5 to 8 minutes, but with now the intraoperative OCT available, you can just see whether the gap between the graft and the host cornea has disappeared or not. After that, you do the suturing. Alright, so this is the pre-op. You can see on day first, it's edema, and you can see little gap between the two. So in this case, we had to rebubble, and over a period of 1 month, you can see the graft becomes clear. So with this, they said the rehabilitation time is about maybe 1 to 3 months, but with the DMEC, within a week or so, there's a quick rehabilitation. So this is the concept, just to make you aware that we can avoid the shortage of the cornea by using one cornea for multiple patients. And again, it's a repetition of what already has been said. And with that, I will end my talk. And if you have any questions, so you don't need a very expensive equipment to do all these procedures. You can do just with your own manual dissection also. There should not be any barrier. Once I will have automated instrument, only then I will do it. Okay?
Thank you very much, sir. I think that was a very excellent practical demonstration. You've seen the videos, so I think you would have developed some concept of what component surgery and how one tissue can be used for 2 patients. So if there are any questions, or we can also have Professor Arya's talk and then questions at the end together.
I think most of the things have already been covered in the previous two talks. So what I'm going to speak will be few things which have been left. Otherwise, I'll be just skipping the slides so that you can have more time for wet lab. So like my topic was, we have two types of DSEC as already discussed. One is automated, other is manual. So indications and various procedures already Dr. Chintan has covered very nicely, so I'm not going to go into those things. So again, anatomy also covered very nicely. So my job has been made very easy by Dr. Chintan and Dr. Arun Jain. So again, indications, DSEC and both automated and manual indications whenever there is a problem to the endothelium. And condition should be that stroma must be clear. If there is stromal scarring, then definitely one cannot go for DSEC, already highlighted very nicely by Dr. Chintan. So prerequisite should be, stroma should be clear, only endothelium problem should be there. So those should be the indication for any DSEC. So pre-operatively we must rule out all these things, like intraocular pressure glaucoma must be ruled out, because if there is a glaucoma then that might cause problem to the human donor tissue as well. So posterior segment, like for any other surgery, it must be done. Then confocal to find out various causes. All this basic workup for any keratoplasty, so that is important for DSEC as well. So again, contraindication, most important, again highlighted again and again, that is stromal scarring. So that should not be there at all. And then sometimes there can be irregular astigmatism with a lot of corneal irregularity. So in that case also it is not going to work. So interior part of the cornea must be clear and it should be regular, only then desperate DSEC will be helpful, otherwise it is not going to help. Sometimes anterior chamber may be shallow. So in that case this DSEC may be difficult to do because there is a very less space for insertion. So then DMEC may be a better option. So basically, surgical technique, there are three steps mainly. One is the donor tissue preparation, second is preparation of the recipient, and third is insertion. So again, many of these things have been covered. I will just tell a few things. So preparation of the donor tissue, once you go outside the wet lab, so we will be telling you how to do manual dissection and how to do automated as well. So both of these things will be demonstrated to you outside, and I think many of you have already done also. So in the manual, what you need is basic equipment, that is artificial anterior chamber. So that is must. So if you want to do this manual dissection of the donor tissue, so you need this artificial anterior chamber. So over that you have to put this corneal scleral rim. So one important point here should be that whenever you are applying this corneal scleral rim, the scleral rim should be larger, because if it is very small, then there will be leakage from the side. So then you will not be able to cut the tissue. So this should be nicely, snugly apposed so that there is no leakage from the side. Then you can go for this. So you can just make one side port, main port incision, then keep on doing the dissection. So this dissection again, it's not that difficult. Only thing one should be very careful that you do not perforate the cornea, especially while making the dissection. So that has to be very careful. So that should be uniform also. If you are in the posterior part of the cornea, then chances are that you are not able to perforate because dissection is very smooth. But if you are in the anterior part, like in the lamellar surgeries, then things are very difficult. So it means that you are not at proper level. So if you are going very smoothly, very easily, that means you are at the proper level. So then after cutting the tissue, then you can cut for the endothelial side, whatever size normally we need for dissect 8 or 8.5 millimeters, that is the usual size we take for the donor. So in automated again, we will be demonstrating outside. So here the things are little bit different. So after, again, you need first artificial anterior chamber. After that, you have to applanate the cornea to see the size. Like again, here we get either 9 mm or 10 mm initial applanating. Then you use this microkeratome. So that is automated microkeratome. So that goes by single pass. Again, you can determine the depth. So like in DSEC, most of the time it will be 500 micron or 450 micron. So you can decide the depth. So once it is done, then you can get this type of tissue. So this is the anterior stroma. So that will be used for, like Dr. Arunjan said, multiple surgeries can be done by one donor. So this anterior part, that will be used for any lamellar surgery, maybe DALC also. But the posterior part, that will be used for DSEC. So by this automated machine, so you are preparing both the tissue simultaneously. So anterior tissue can be used for self or lamellar surgery, while the posterior part will be used for DSEC. So that again you take on the Teflon block and then you define it, punch it with whatever size, 8 or 8.5 millimeter, then accordingly you use it. So again it can be also a single pass technique, mostly it is done, then double pass also where initially less thickness is used, then you can go further with another maybe 100 or 150 micron depth. So that is double pass technique. So any of the technique as per the surgeon choice can be used. So again, automated versus manual, what is the difference? So basically, there is hardly any difference, but usually there is a smooth dissection with the automated, and dissection is very smooth and very, you can say, nice. So post-op interface haze, that will not be there. So that is the advantage. And the other thing is whatever depth of the tissue you want, so that you can get only by automatic, not by manual. So in the manual it is a guesswork, just by experience one learns how deep you are and whether the dissection is smooth and uniform or not. But with automatic, definitely you can have very good dissection, so that's why vision will be usually better than that. So nowadays, like when pre-cut tissue, these are also available. So like anyone wants to do DSEC, so you can get pre-cut tissue from various eye banks. So they are donor tissue that Desmet or the with endothelium, that will be available. Yes, you have to then insert one. So that procedure, in fact, it is already done in certain eye banks. So they are supplying this pre-cut tissue also. So then how to prepare this recipient? So again, desmetolexis is the main part, which again Dr. Arunjan has shown very nice video. So again, first one is to mark the cornea on the epithelium side. Then after making the section, then you can use a reverse tube where you can nicely score the cornea, just like you do capsulotomy in the phaco. So then after separating it from all sides, then you can just remove it from the main section, main port. Then rhexis is done. So after that, so sometimes this Desmet is very tough, like in this case it is very tough, so it becomes very difficult. But you have to just remove it very nicely from all sides without damaging the stroma. So there should not be too much pressure applied to the stromal surface. Just apply all around this reverse tube, then you will be able to separate it. So then last one is the insertion. So there are different techniques of insertion. So one is Brusen glide, like outside we are showing you how to insert with Brusen glide. So with Brusen glide you need pulling technique, while there are other techniques by which you can push also. So like this is by Brusen glide. So you take the donor tissue on the Brusen glide, then on the main port section. So like we have taken on the Brusen glide, after putting viscoelastic, endothelium should be on the upper side, then you have to reverse your Brusen glide. So initially it should be facing up, then it should be facing down towards the wound. Then one can go from the 6 o'clock position, from where you will pass the forceps, and then you will pull from the Brusen glide, and then it will be pushed or it will be pulled. So this is called as pull-through technique. So like outside we are demonstrating this technique, so you can see how exactly it is done on the human eye. So I'm not going to details. So the second is folding. So again, Dr. Arunjan has shown very nicely. So this is another where you can just fold also, again 60-40 ratio. So again, so that you can unfold very nicely. So you can hold with the forceps, and then immediately you have to inject the air, then it will automatically, it will unfold very nicely. So important thing is it should be have some mark. So if mark is not there, you will not be able to know whether which side is up and down. So stromal side should be on the stromal side, and endothelium should be always down. So that is very important. Otherwise, if it is reversed, then it will be very difficult to rotate it. So then there are few other techniques also like sheet glide. So again we have made one not sheet glide we have outside. So by that also you can learn how to put with the sheet glide. So by that what do? We put sheet glide and over that we apply the donor tissue. So then the donor tissue that will be guided by the sheet glide. So by that also you can insert in the anterior chamber the donor tissue. So you can see there is sheet glide along with the donor tissue. So then you can remove the sheet glide and the donor will be left inside. Then you just inject the air. So that is another technique for insertion of the donor tissue. So these are just again different studies. They have said that if you hold by the holding forceps, this is the area which will be damaged by the forceps. So it should not be crushing forceps. So that is very, very important. So there is special forceps for that. So only with that. Otherwise, if we hold with any forceps, it may crush the tissue. Then there will be more damage like this. So with glide, you can see this type of cell damage. So mostly it is seen that with forceps, definitely there are more endothelial cell damage. Then there are another inserters also for endothelial tissue, that is endoglide or the endo-inserter. So by that also one can put this endothelial tissue. So after preparation of the endothelial tissue, so this is the endoglide. So personally I have not used it. So by this, again it is very, very simple to use it. So endothelium is put inside this inserter. Then it is just like injector, just like any intraocular. So you have seen injectable lenses. So injector, same thing is there. So intraocular lens, just like endothelium, that is taken into the inserter, then that is injected in the anterior chamber. So then automatically, just like any other procedure, you inject the air and it will unfold in the anterior chamber. So this is another with endoglide technique. So you are first taking endothelium tissue in the glide, then you will inject it. So any of these techniques, so it depends on the comfort of the surgeon and affordability, because these inserts, they are very costly. So holding forceps, so any of the technique one can master, and then accordingly one can use that technique. So there is hardly any difference of any techniques as far as the results are concerned. So one can get skill in any of these techniques. So after proper folding, then it should be injected. So again, personally, I don't have this experience of this technique. So we are using basically a Bussen glide type with pull-through technique. So that is, I'm more comfortable in that technique. So loading is very, very important, which side is up and down. So while injecting again, it can be up and down, so one should be very, very careful. So marking is going to help in that situation. So after loading, it is just like any IOL injection. So as you put IOL in the bag, it is same thing. You are going to inject in the anterior chamber, taking care that it opens, not upside down. So that is glide technique. Then post-operative management is not very difficult, just like for any PK. It is same thing, we have to give topical steroids in Desmic, because endothelial injection can be there, so mostly oral steroid should be given in all these patients. Topical antibiotics, just like any routine management for these patients. So this is how this looks like on anterior segment OCT after you do dissect. Then complication, I think there can be so many complications, but for your level at this stage, I don't think they are so important to discuss. But you must remember that there can be graft dislocation. That is the most important complication. One should be careful during surgery and post-operative also. So sometimes there can be rebubbling requirement also. If there is a displacement or dislocation of the graft, one can rebubble again second day. Then if the donor quality is not very good, then primary donor failure can happen in dissect, because there is a too much 20 to 30% cell loss can be there in the beginner, especially in the person who are not very expert in dissect. So because of that loss, initial cell count must be good quality tissue, only then you can have good results. Otherwise primary donor failure can be there. Then coma or epithelial growth, so these are not those important complications. Important thing is there are no sutures, so no suture-related complications are there. So no astigmatism, no suture infiltrates, those are the advantages of dissect. So again, just to save time, I am not going to these theoretical things. So I think that's all. That will be discussion. Anything again, this we already discussed whether PK or dissect. Dissect is better because it's sutureless, so no astigmatism will be there and smooth surface, and you are not replacing all the layers. So no epithelial rejection, no stromal rejection, only endothelium you are replacing. So that's why only endothelial rejection will be there. So those complications, rejection, those also will be less in this technique. So with this, I can go to this talk. Thank you very much. Any questions we can have?
Yeah, thank you, Dr. Arya, for again highlighting the different modes of lamellar keratoplasty and advantages and disadvantages of various techniques. If you have any queries, feel free to ask anything. No? So this is very important. Any refractive surgery, any cornea or lens-based surgery is a refractive surgery, and the only wow effect is only in cornea and cataract surgery. No, suddenly patient from just counting finger or at 1 meter starts seeing very good, which is not so in other types of surgeries. No, so that's why technically also it's much more demanding. You have to take care of nuances of surgery. So if any one of you, that's why the training part is also a little different as compared to the other types of ocular surgery, because here the potential is almost 100%, no, for the vision compared to other things, other types of. So those of you who wants to pursue cornea, cataract and refractive surgery, patient gets a wow effect, and of course, you have to. Okay, so now I think whosoever is, yeah.
All of you who have registered for this DSEC, so you can go outside, and manual as well as automated, both the things you can learn, and you can, some of the steps will be done by yourself also. So you can just go outside and you can learn DSEC, manual and automated both. Anyone who has done outside already, so they can tell any problems on wet lab.
Anybody sitting in this hall has done the wet lab in the morning?
I think there are 2-3 students, yeah.
Learned and gone.
So those who have done, they can tell any problems or anything you faced or you learned, it was okay. I think students are quiet, they're not speaking.
It's important to get the concepts clear, what surgery to do when, and then you have a very good setup outside, so you should make the most of it, I think.
All right. Okay, now we disperse for wet lab and lunch, and lunch also. So thank you so much, all of you.
Thank you.
There are very few people, यार. एक तो जूही अपनी है, एक सीनियर रेजिडेंट मौर्या बैठा है. जब तक सुरेश नहीं बैठेगा ना.
we'll start. So, good afternoon, friends. I welcome you all to the session on lacrimal system and the two disorders which affect it very commonly and which we encounter them in the clinics frequently and have to manage them. One is the congenital nasolacrimal duct obstruction, the other one being the same obstruction in an adult coming with dacrocystitis. So today, just to make you familiar with the lacrimal system, Dr. Sonia is going to cover the anatomy. Dr. Sonia, please.
Yeah, thank you, ma'am. So I'm so sorry that I cut short your lunch time. Before I start my presentation, I would like to thank Dr. Suresh Kumar and GMCH team for giving me this opportunity. So I'll be covering the basic anatomy of lacrimal drainage system, and I'll be very concise, and I hope that I'll make it very informative to all of you. Okay, so let's start the anatomy of the lacrimal drainage system. As we all know, that the system consists of two components. One is the secretory component of the lacrimal drainage system, which helps in the formation of tears, and the second is the excretory system, which helps in the drainage of these tears. Right? So first, the important part of the tear production system or the secretory system is the lacrimal gland. So lacrimal gland is a kind of exocrine gland, and it's situated in the superolateral quadrant of the orbit within the lacrimal gland fossa. And it's been divided by the LPS muscle aponeurosis into two parts, orbital part and the palpebral part. The palpebral part can be seen by just everting the upper eyelid. Fine. Then the duct of the orbital part opens into the palpebral part, and from this palpebral part, 10 to 12 ducts of the tears, they open into the superior conjunctival sac. So, though the major part of the lacrimal gland is formed by the orbital part, but whenever we are planning to do any kind of biopsy or surgery over the lacrimal gland, it is preferable not to touch the palpebral part because they are the main draining channel of the tears secretions from the gland, right? Then coming to the other glands, these are the accessory glands, glands of Cross and Wolfram. So as you can see that the glands of Cross, they are situated into the superior fornix, and the glands of Wolfram, they are situated approximately 5 mm above the upper end of the tarsal plate, right? Then this lacrimal gland are mainly supplied by the lacrimal artery and the lacrimal nerve. So functionally these glands are active only after 6 weeks of the birth. That's why there are no tears in newborn on crying. Fine. Then coming to the important one is the excretory system, which helps in the drainage of the tears. So we have the punctum. So we have two punctum, one at each medial end of the canali lids. The lower punctum is slightly lateral as compared to the upper one. Why? Because of the faster growth, faster embryological development of the maxillary part as compared to the frontal part, that causes the slight lateral shift of the lower canaliculus. That causes the slight lateral shift of this punctum, right? Then coming to the canaliculi. So canaliculi also have two canaliculi and has two parts, vertical part as well as the horizontal part. They are perpendicular to each other. The vertical part is of approximately 2 mm and the horizontal part is of approximately 10 mm. So tears drainage from the punctum towards the canaliculi. So 90% of the time, these canaliculi, the upper canaliculi and the lower canaliculi, they join together and they form the common canaliculi before just entering into the lacrimal sac. Fine. The angulation of this canaliculi helps in the or prevents the flux of tears from the lacrimal sac into the canaliculi. And one more important thing is that there is a presence of valve of Rosenbluth over here in between the canaliculi and the opening over the opening into the lacrimal sac. That also helps in the reflux of tears from the sac into the canaliculi. Then coming to the important one is the lacrimal sac, which has three parts. The part which is above the opening of this canaliculi is called as the fundus of the sac, which is of almost 3 to 5 mm in size or in the length. And the second part is the body of the sac, which is of almost 10 mm. And then is the neck, which forward in continuation with the nasolacrimal duct. Then the fourth important part of the excretory system is the nasolacrimal duct, which will be discussed detailing later. Fine. Now coming to the important one is the osteology of the lacrimal sac fossa. If we are planning to do any kind of surgery in and around the lacrimal area, one has to know a thorough knowledge of the lacrimal anatomy. So the lacrimal sac fossa is situated. The lacrimal sac is situated into this fossa, which is present inferior-medially, okay, and this is bordered by the anterior lacrimal crest and the posterior lacrimal crest. Fine. So this anterior lacrimal crest is the continuation of the maxillary bone, and the posterior lacrimal crest is formed by the lacrimal bone. Fine. Then there is the importance of the anterior lacrimal crest, and why it is important, because the anterior limb of the medial canthal tendon is attached over the superior border of the anterior lacrimal crest. Fine. So if somebody wants to expose more exposure of the lacrimal sac area, then one has to detach the MCT from the anterior lacrimal crest. Okay. Then there is one more important suture, which is known as the maxillary lacrimal suture. So maxillary lacrimal suture is the junction of the maxillary bone and the lacrimal bone. So the position of this bone is important for the surgeon, because suppose the suture is present more anteriorly, means this fossa is mainly formed by the lacrimal bone. So why it is important to know? Because the lacrimal bone is more thinner as compared to the maxillary bone. So surgeon has to do less effort to make osteotomy. Fine. And vice versa, if the suture is situated more posteriorly, it means that the fossa is mainly formed by the maxillary bone. Right. Then one more important suture over here is the sutura lotha, which is the landmark for the infra-orbital artery. So one has to make sure not to damage this artery, because it can cause the profuse bleeding intraoperatively. Fine. Then coming to the relations of the lacrimal sac. So medially, anterior ethmoidal sinus superiorly, and the middle meatus of the nose inferiorly. And if we go from anterior to lateral side or from the anterior to posterior side, first relation is the skin, then the presence of the angular vein. So angular vein is the most important structure while giving incision. Mainly it is situated 6 to 8 mm medial to the medial canthus, right? So one has to be very sure while giving incision for the lacrimal surgery, and it has to be given like 4 mm medial to the medial canthus. Right. Then beneath this angular vein is the palpebral fibers of the orbicularis oculi muscle, and then there will be presence of MPL, and then there will be fibers of the orbicularis oculi, the lacrimal fibers, and then the sac will be covered with the lacrimal fascia. Then coming to the next important part of the system is the nasolacrimal duct. So nasolacrimal duct, as we know, that is a continuation of the lacrimal sac only, the neck part which goes below, and it has two parts, intraosseous part and intrameatus part. So intraosseous part is situated, it lies in a bony canal which is formed by the maxilla and the inferior turbinate. So the part which is present in this canal is known as the intraosseous part, and which is beyond this, inferior to this part, is known as the intrameatal part, which is in the inferior meatus. Fine. So the direction of the anatomy is very important. The direction is downward, backward, and lateral. Surface marking for the NLD is the line joining the inner canthus of the eye to the ala of nose. Fine. And then we have the valve of Hessner, which is very important, which is situated at the lower end of the nose, which prevents the reflux of air as well as tears from nose into the NLD. The narrowest part of the NLD is the upper end of NLD. Then what are the structure NLD has in and around it? The epithelium of the NLD is the superficial layer is formed by the non-ciliated columnar cells with the goblet cells, and deep layer is formed by the flattened cells. The subepithelial tissue of the NLD consists of lymphocytes. Then the fibroelastic tissue of the NLD, it is in continuation with that of the canaliculi only. And then there will be plexus of the vessels around the NLD, and the engorgement of this plexus can cause the epiphora. Now coming to the arterial supply and the venous supply of the lacrimal area. The arterial supply is from the palpebral branch of the ophthalmic, angular and infraorbital arteries and nasal branch of the sphenopalatine artery. The venous drainage above the nose or upper area is drained into the angular and infraorbital vessels, and the lower part is drained into the nasal veins. Lymphatic drainage, the submandibular and deep cervical node steps in the lymphatic drainage, and the infraorbital and anterior superior alveolar nerve helps with the nerve supply. So the take-home message is that the successful lacrimal surgery begins with a thorough history and pre-op clinical examination, both of which guide the surgeon to correct the diagnosis and appropriate management. But yes, thorough understanding of the anatomy of the lacrimal system will further facilitate the chance of successful surgical outcome. Thank you. Thank you so much.
Thank you, Dr. Sonia, for covering the anatomy of the lacrimal gland and the lacrimal sac extensively. I hope this will be useful as we proceed with the steps for surgery in this area.
So the next talk will be by Dr. Usha Singh. She is Chief of Oculoplastics at PGI Chandigarh. Her talk will be about all you need to know about CNLDO. And regarding the previous talk by Dr. Sonia, please remember that whatever the images she has shown, we'll see it in the cadaver downstairs.
Good afternoon, everyone. Thank you, Dr. Suresh, for giving me this opportunity to share with the students over here. So I'll be talking on congenital nasolacrimal duct obstruction. Congenital nasolacrimal duct obstruction is a common condition in the pediatric population, causing excessive tearing or mucoid discharge from the eyes due to blockage of the nasolacrimal duct system. And we can see the matting of the lashes above and the area involved. And it mostly gets resolved spontaneously without surgery in the majority of the patients. In the epidemiological studies, 5 to 20% in the early phase of childhood are affected. And this study by McEwen et al., in a large study of 4,792 infants in UK, they found a prevalence of 20%. And 95% of these children were symptomatic at 1 month of age. The pathogenesis, there's a mechanical obstruction located distally in the NLD at the valve of Hessner because of the pathological persistence of the membrane and or bony abnormalities or stenosis of the inferior meatus. It's mostly unilateral in 80%. How is it diagnosed? We do the fluorescent dye test. So we put a drop of fluorescent in the conjunctival inferior fornix. And we look for the clearance of the dye from the tear meniscus in both eyes in over 5 minutes. So if we still see there's no reduction of the dye, then we know that there is a blockage at the NLD level. Before that, we must rule out glaucoma and foreign bodies and corneal infections. In congenital NLDO, infection is limited to NLD and occasionally causes conjunctivitis. Spontaneous resolution is known in congenital NLDO, and it's about 93% in first 8 months and 44% between first and second year of life. The treatment options can be divided in those children less than 1 year, where we can just observe them and combine them with conservative options. And in children more than 1 year, we can do NLD probing, and this NLD probing is very well established and accepted worldwide, and this leads to it successfully addresses most of the obstructions. However, the ideal timing of probing is controversial. We'll be discussing this later. So failed probings, refractory cases where there's persistent epiphora, mucoid discharge, we have many options. We can repeat probing with the inferior turbinate fracture. We can do silicone tube intubation, balloon catheter dilatation, and when everything else fails, dactylocystorhinostomy can be done. So coming to the conservative treatment methods, first is the massage. This is widely accepted, and this technique was first introduced by Krigler in 1923. This is a downward rotation of the thumb over the tear sac in order to break the membranous obstruction by increasing the hydrostatic pressure. The pediatric diseases investigative group, they did a study, a randomized control study. They looked into the cost effectiveness and they compared immediate probing versus conservative massage. And they found that 2/3 of the obstructions, they get relieved in age 6 to 10 months. So the success rate is 56% after the first attempt in children, less than 2 months. We are talking about the massage over here. It's 46% in 2 to 6 months of age children, and 28% in children more than 6 months. And this author, Karti et al., he did a study among the parents who did regular massage versus infrequent massage. And there was a gross difference, and it was significant that 96.2% success rate was found in those who did regular massage, and it was only 77% in infrequent massage. So this information is useful to us while counseling the parents. What is the role of antibiotics? Antibiotics do not resolve the obstruction. However, they help in balancing the possibility of avoiding the local spread of an infectious process from the lacrimal sac with the risk of developing resistant flora causing an NLD chronic infection. Its irrational use facilitates the overgrowth of resistant bacteria, and it's indicated only when there is evidence of infection or there is matting of lashes. Now we come to the invasive treatment. So the first line treatment in invasive treatments is irrigation in conjunction with probing. Second line treatment is repeated probing, silicone tube intubation, and balloon dilatation. Probing without irrigation has overall success rate in 83.5% of children with congenital NLDO. 90.2% success in children less than 2 years, and 78.9%, almost 79% in children more than 2 years. So probing with irrigation has similar results. So it is the individual choice of the treating surgeon. Now coming to the primary probing, it's most commonly adopted surgical procedure in the management of congenital NLDO. It requires passing a probe down to the distal portion of the NLD system in order to break the obstruction. The timing of this probing, as I said earlier, it is controversial. There are two schools of thought. So coming to the first, those who propagate early probing, that is when the child is 6 to 9 months of age. In such age group, the probing is technically more challenging to manage an awake and often crying child. However, the arguments which they put forward is that it avoids the risk of general anesthesia. It also avoids fibrosis which may occur due to the prolonged chronic inflammation of the NLD. However, subsequent studies have done to look for this fibrosis and they did not find anything. Now, for those who propagate late probing, that is more than 12 months of age, it's less of a technical challenge for the inexperienced surgeon. The success rates are comparable to the early intervention. So, the actual procedure of probing is, there are basically 4 main steps. We dilate the punctum, pass a probe to make a hard stop, pass through the canaliculus, pass the probe into the NLD, confirm that the probe is in the nose. As we can see in this diagram, it's difficult to point out from this position. So I'll just say that first we have dilated and the probe is put. When we are with our thumb, when we pull the lower lid, the puncta is facing up. So we put the probe, it has to be done very carefully and make sure not to use a very sharp punctum because the soft tissue in these children or infants can get damaged. So we have to exercise a lot of care while putting the punctum and gently rotate to dilate it. After we have dilated, we put the probe vertically first for about 2 millimeter and then we make it horizontal to the direction of the canaliculus and gently pass it medially till we feel a hard stop. Once we've held a hard stop, and this can be helped by pulling the lateral canthus laterally. After that, this probe is rotated 90 degrees up. The anatomical landmark is the supraorbital notch. So, and it should be not standing obliquely, but touching the skin and on the supraorbital notch. So that's just a guide. But at the time when we are rotating in 90 degrees, we must take care that we don't keep stretching the lateral canthus or else we will tear the punctum. After that, once it is in position, we just pass this probe down till we feel a obstruction, a soft or a hard, whatever it is, and we gently push it. And most of the cases, we just need a gentle push and we get a popping sound. But this popping sound is not a must. So in about 2% of the patients would be having a bony obstruction and it will not be possible to pass it further. So at that time, we must stop and not keep continuing our maneuver so that to avoid further damage. The success rates of primary probing. Early probing gives us a success rate of 75 to 89%. And it reduces the symptoms of symptoms in about 3 months of symptoms in the infant, and it's slightly more cost effective. Coming to the late probing, the success rate is more or less the same, 75 to 85%. And this author, Rajavi et al. In 2014, they specifically looked into the success rate in different age groups, and it was 85% in 2 to 3 years old, 63% in 3 to 4 years old, and 50% in children aged 4 to 5 years old. And Napier et al.,
they've done a retrospective study and they found the overall success rate of primary probing in the late period to be about 75%. But they included all age groups. This is 0 to 9.8 years. So this was a mixed group, and it is regardless of the gender, age, complexity of the obstruction. We must remember that probing is not without complications, and complications are noted more in the hands of a novice or the uninitiated. Probing we must remember that it's an invasive and blind procedure. It can lead to bleeding, damage of the nasolacrimal duct system and of the adjacent structures. Inflammation can lead to subsequent NLD fibrosis. Bleeding from the lacrimal punctum during the procedure is noted in 20% of the patients caused by the formation of a false passage. Hence, the possibility of resolving congenital NLDO in 2/3 of the patients with only simple observation should be carefully taken into consideration. Endoscopy-assisted nasal probing. Now, recent studies by Corey, Theodore, and Al-Faqi, they have found that using endoscope has improved the success rate of this procedure. It reduces the likelihood of complications. This is done under GA, maybe in collaboration with or without other specialists. Allows for a direct visualization of the NLD system and the possibility to fracture the inferior turbinate in case of bone abnormalities. Thus, given the invasiveness and high skills required by this intervention, endoscopic nasal probing should be considered an efficient second-line treatment of children with NLDO. So here is a endoscopic assisted probing, and we can see the inferior turbinate and inferior turbinate recess. We can see the steel probe which is being. So this will confirm that you are in the right place and you have not made a false passage. Repeat probing. As there's a study done by this pediatric diseases investigative group in 2009, and they studied the children with relapsing congenital NLDO in the age group of 6 to 8 months, and they found a success rate of 56%. Katowitz et al., they found success rate of 52% in 6 to 18 months and 18% in 18 to 24 months. So you see the success rate is decreasing as they in repeated probings. So this suggests that reduction in the success rate of the secondary probing is likely due to complications of the primary procedure, such as cicatricial stenosis or false passage formation. Other procedures are silicone intubation, mainly for treating complex congenital NLDO after failed probing, and the success rate is 62% to 100% reported. Monocanalicus tubes have now come in, and it is now being adopted by the oculoplastic surgeons in the management of primary congenital NLDO. This pediatric diseases investigative group, they found a success rate of 90% with silicone intubation, but this study has its own limitations. There was no control group. There was a high rate of tube removal, 41% before the completion of the study, before 2 months, that is. So this indicated that there is a high dropout rate due to low compliance. Balloon catheter dilatation, this is more recent procedure, and it gives us a success rate of 77%. However, we must keep the cost factor here in mind. Dacryocysterinostomy is a nearly perfect solution to this obstruction, but this is used as a last resort when everything else fails. So coming to the conclusions, probing is considered the first-line invasive treatment for congenital NLDO. Since results with early and late are comparable at 3 years, it is reasonable to wait for at least 1 year. In Indian scenario, other factors come into play, hence these should be considered. First of all, we need to assure the patient's attendant about the course of the disease and spontaneous resolution. We must properly educate on hygiene and massage and the use of medication. The distance traveled and the willingness to wait and return for invasive procedure should be assessed. If you feel this patient would not come back on time for a surgical procedure, then you schedule the probing much earlier. Hygiene levels and number of episodes of dactylocystitis also should be considered, as repeated episodes of dactylocystitis is generally noted with poor hygiene. And in the Indian scenario, as we must all have seen, that mothers keep using the same cloth or handkerchief or the dupatta or something to keep rubbing the eye and the nose alternately or throughout the day. So another consideration is working mothers. Whether can they do massage 10 times a day or 5 minutes 3 times a day. So seeing the scenario and how the mother's schedule is, time schedule, you can take a call on that. So it has to be individualized. For failed complex cases, balloon catheter intubation and endoscopic dactylocystic rhinostomy is always there. Thank you very much. I would call upon Dr. Manpreet now to give his talk on dactylocystic rhinostomy.
Thank you.
Any questions from the students? Would anybody like to ask any question?
I think there is no question because ma'am has covered everything very extensively. But one should know that the congenital NLDO is a very common disease, and the assurance to the parents, especially mother, is a very important topic, and they have to be counseled very effectively. And every and each patient, parents, they always ask you whether the antibiotic will work or not. So, as ma'am already said, the importance of the antibiotic is just there is no role of antibiotic until unless the patient is having any kind of discharge, right? If the patient is not having any kind of discharge, then there is no role of antibiotic. Just ask the parents to do the massage, and then the massage is actually, for the first 6 months, the massage is very helpful.
Till the time my laptop is being set up, we have covered two very important topics in dacryology. One was anatomy and second one was CNLDO. So now the third topic which I have been given by Dr. Suresh, and thank you Dr. Suresh for having me here. GMCH is my alma mater, and I always love being here. So my topic is indications and surgical techniques of DCR. I am Manpreet. So what is DCR? DCR, the full form stands for dacryocysto rhinostomy. Dacryo being lacrimal, cysto that sac, lacrimal sac, rhino means nose and stomy means open. So what we do is we open up this lacrimal sac into the nose. Why we do this? Because there is obstruction over here in the nasolacrimal duct. The nasolacrimal duct gets blocked. So remember the pathology here or the diagnosis for your surgery. In the OT list, one should write that there is nasolacrimal duct obstruction, okay, which can be acquired or primarily acquired or secondarily acquired because of trauma or something. Hence, it's a bypass procedure. Remember, this is a bypassing of nasolacrimal duct. Simple. So what are the indications of DCR? What madam has covered in CNLDO, one, it becomes unresponsive to balloon dacryoplasty or lacrimal intubation, or up front there is NLD agenesis. There is no nasolacrimal duct. In case of pando, primary acquired nasolacrimal duct obstruction or in secondary cases. Like in this case here you can see there is a large abscess present in the lacrimal sac region. How come this is lacrimal sac region? Abscess because the medial canthus you see, and right from the history and all, and in examination you can see the medial canthal tendon itself is pushed up. And not in this case, but in routine cases, you can always, patient can tell you that while pressing upon the lacrimal sac region, there is evacuation of discharge. So from this talk, I'll only say, okay, look here, only 2 goals of DCR, remember it by this talk, just 2 things. 2 goals are there. One is to make a large bony osteotomy. Secondly, cover it with mucosa lined anastomosis. Mucosa means of sac and nasal cavity. Just cover this. This will give you adequately and a beautiful ending to DCR. Incisions of external DCR. Okay, first the routes. Okay, routes can be transcutaneous, transnasal or transconjunctival. Transconjunctival has been also described as an aesthetic one, but usually people don't do it. Kind of more lengthier procedure. So transcutaneous you can have 2-3 kind of incisions. This is Lynch incision, not long practice much, but this is a incision over the anterior lacrimal crest, the second one. And if you want to go for more aesthetic one, then you can go via the subciliary incision. Remember, you should always take care to bluntly dissect rather than cut the fibers of muscle. So routine steps, how many of you guys have seen external DCR happening? Raise your hands. So many, great. Around, I think 40%. Endoscopic DCR? Oh. Okay, so external DCR you guys have seen, and rest of us will be having the cadaver dissection over in the ground floor. So in DCR, what we usually start, the patient can be under GA if the patient is a child, or usually done under local anesthesia. Nasal packing is first and most important step. This is a gauze piece soaked with xylometazoline, okay, to decongest the nasal mucosa. And once the nasal packing, proper nasal packing is done. So see in this image, you can see the Tillies is being targeted towards the tip of the roof of the nasal cavity. We are not going to pack the floor of the nasal cavity. Okay, remember we are going to target the middle meatus region or middle turbinate region. So once the proper packing is done, which is the decongestant soaked gauze piece or a Marocin pack, what we use routinely, then the incision is marked. This is the left side. Okay? Remember, this is left side. This is kind of anterior lacrimal crest incision. So once the incision is fashioned with the 15 number blade or RF cautery, whatever you prefer, then blunt dissection of the orbicularis is done. You reach the bone, periosteum, give incision over the periosteum, lift the tissues with the periosteum, and then here you go, you will see the lacrimal sac. I don't know if you guys are able to see this bluish thing over here. This is sac, this is the tissue what you are being, this is kind of a edge of periosteum, okay? And this is the skin and muscle, and this is edge of periosteum what you are lifting. This is the bone, and this bluish structure is lacrimal sac of the left side. Then once this is exposed, as Sonia in her first image showed, that either the lacrimal sac can be maxillary or lacrimal predominant. So once if it's lacrimal predominant, so then surgeon has to do lesser risk osteotomy, because maxillary bone only needs punching, lacrimal bone only needs removal. Okay, so this punching is done with Garrison punch, and we create an osteotomy over here. And remember those 2 goals. First was to create a large, good osteotomy. What is the upper, lower, anterior and posterior demarcations or landmarks where we should stop? The superior one, once you have put the probe in from the upper punctum and canaliculus, you keep the probe horizontal. Okay, look here. So once the probe is horizontally placed, okay, then if the bony osteotomy is going above it, okay, like you can see the tenting while the probe is being horizontally kept. ऐसे cheating नहीं करना है. You keep the probe horizontally, and then if you are able to see a tenting, that means superior osteotomy is nearly complete. We need not to go beyond much, because as she told, 3 to 5 mm of sac is having the fundus. 3 to 5 mm ज़्यादा नहीं होता है. Just you see the tenting, okay. Superior osteotomy is done. Inferiorly till you reach the nasolacrimal duct opening. Nasolacrimal duct opening, once you have reached, the pathology lies over there. So we are not going to dissect the pathology, we are going to open the sac. So till you have reached the bony NLD, stop there. Inferiorly, superiorly, horizontal probe pass करके देखा, osteotomy is going well beyond it, okay. Superior, inferior done. Anteriorly, you have to go, the punching should continue till you encounter orbicular oculi endoscopic DCR, or your punch doesn't go, don't in between the mucosa and the bone. Okay. That time you have to realize that here the orbicularis is much more firmly attached. Okay. So that is the end point. Posteriorly, you remove the lacrimal bone, you are done. And roughly your ostium should be around 15 millimeter average size. 13, 18 is okay. In endoscopic endovascular DCR, this is, can you tell me, madam, what side nasal cavity is this? Yeah, which side? Is it right side nasal cavity or left side? Left side nasal cavity, excellent, yes. So this is the lateral nasal wall from where the turbinate is arising. Here lies the septum. Okay, so this is our area where we operate. Here lies the sac, and the maxillary line is the important, very important anatomical landmark. You fashion the incision over here, remove the bone, and here you go. Once you have removed the bone, direct visualization of the lacrimal sac. Remember, NLD is obstructed. We need not to go there. We need to open the sac via endoscopic route. Just remove the nasal mucosa, remove the bone. There you go, sac is there. Okay? No cutting or fiddling with the muscle or skin. So some advantages of endoscopic DCR. There is no cutaneous scar. No one wants a scar in modern era. It's a practical point. You will see in clinics. Minimally invasive procedure. It preserves the lacrimal pump or the orbicularis oculi function. And in revision DCRs, it gives you more predictability, and you can actually identify why your previous surgery has failed. Was there a gross DNS? Was there subtonasal synechiae? What has happened actually wherever you have, the ostium is opening in the nasal cavity. Go in the nose, see, look where the ostium you have made, and then look for the, try to decipher why your previous surgery failed. And yes, it's a great imaging tool. External DCR, we all work in a very narrow field, and surgeon or one assistant, lucky one, can have good visualization, or one we can stop and while we are teaching, you can have a peep into the thing, and if you are really seeing, then you can say dikh gaya, but it's all, sometimes it's a great teaching tool. You, whatever surgeon is saying, the assistant is saying. However, remember, external DCR is still the gold standard. It's a very good surgery, takes lesser time, I must say, easy to learn, lesser learning curve, but these are the advantages of endoscopic DCR. And thank
you. Dr. Suresh, we have some time for discussion. Okay, so I would like to ask the students, what is the biggest complication of external DCR? Why people are hesitant to do DCR? Come on, not that difficult. Pardon?
Surgeon, not the patient.
Hemorrhage. Yes, excellent. So bleeding is one complication we need to know how to control. So I would request Dr. Manpreet to elaborate on that, how to go about controlling the bleeding in external DCR for the sake of residents.
Okay, so I have learned the external DCR and art all from Dr. Usha Singh. I was senior resident posted with ma'am, and the first external DCR I went with under her guidance. First thing what she always teaches, patient ka BP, control the parameters. First the patient's parameters should be controlled, blood pressure or whatever, is the patient on blood thinners or something, you have to take care. Even you have to operate the patient. ऐसा नहीं है, the patient is on ecosystem, you can't operate. You have to take proper precautions, 7 or 10 days, or as cardiologist advise, stop the medications, control BP, keep the the operating table, just lift the head up around 10 to 15 degrees. That will give you better visualization. And remember, the bleeding happens at 2 steps, primarily 2. First, if your incision is not at right place and you have accidentally incised the angular vessel, what Dr. Sonia was telling. Don't incise vessels, so don't cut basically. Just try to separate. Blunt dissections, you will have minimum bleeding. While dissection, your target is to reach the periosteum. Do it. Blunt dissections. You will not have bleedings. And retractors are put to, and even if you have it, what you can do is, the vessels are going by the muscle. You can just replace your retractor and try to control the bleeding with the pressure of the retractor. First thing, vessels, they bleed. Second thing is nasal mucosa. Once the osteotomy is done, it's a good step if you just take out some time to get anesthesia, which is having adrenaline loaded in it. Remember anesthesia, I'm talking about xyloclast ADR, not fresh, not a diluted ADR. You inject it in the nasal mucosa before fracturing the nasal mucosal flaps. 2 steps. If you avoid these 2 steps, you will not have major bleeding.
Thank you, Dr. Manpreet. And I think in interest of time, we must stop here. And if any student has any question, they can ask us later on also. Yes? Just one question, please. Yes.
No, Sonia told something. It was 6 to 8.
6 to 8.
From
Either
the medial canthus.
On the medial canthus. Either we give incision before 6 mm or 8 mm posterior to it. Which incision is better?
Okay, good question. So, you have to avoid the vessels. So, what he is trying to say, this is medial canthus. Okay, this is my left medial canthus. This is angular vessel. Either towards medial canthus, we should give incision, or away from medial canthus. 6 to 8 millimeter area, avoid that. Okay. It's always good to be near the medial canthus because that is the 3D area and your scar will not be visible much. The more you go away or towards the center of the midface, your scarring will be more and it will be more visible and you will have more webbing.
There's one more point which I would like to add. See, most of the patients who come from Himachal and some of the north areas, they have very deep set eyes. Okay, so if you keep the incision away from the canthus, it will be very difficult to go deep down to dissect the lacrimal sac. Okay, but some of the people who come from the northeastern regions, they have a different features. So there you could go a bit away from the thing. But only thing just to remember not to cut the vein, and in case it's cut, not to get panicky, just cauterize it, simple.
We have cut it so many times.
Yeah, so only thing, one should not get scared of bleeding. We should learn all the ways how to control the bleeding. Okay, and another thing in controlling the bleeding is about if patient has had any nasal infection, at least wait for minimum 3 weeks. Because, because I still remember when I was a young faculty, the patient had had nasal infection, and we took a clearance from the ENT. They gave a clearance. From their side, patient is okay, but so we took up the patient for surgery 2 weeks later, after the antibiotics and everything had subsided. But this patient bled so much, and but somehow we managed the surgery. He was all right in the immediate post-op, but the infection recurred, and he bled on the, in the post-op care. And we had to give him a unit of blood. That much he bled. So I think these are some learning small points that give them sufficient time, that the congestion always remains. It doesn't go away totally in 2 weeks' time. So
we operated one case within 6 weeks period, and after operation he had fistula.
Yes. Okay, thank you. We are open to questions later on. So I would invite the next session, Dr. Hinav Kaur and Dr. Jaspreet to take over the session on neuro-ophthalmology nuances.
With the concluding session, and that's neuro-ophthalmology. It's a very vast topic, but one should know, because you have so many, you can say so many patients coming up with disorders which are like confusing, and neuro-ophthalmology's evaluation is something where you can just clinically do an examination and have clues to what you're dealing with. Unlike other parts of ophthalmology where you would like to investigate before coming to a conclusion. So these things, a good examination, a neuro-ophthalmic examination, would give you a clue to a lot of things. So we'll start off with the Dr. Hinav Kaur, and she'll be discussing about some of the basics of neuro-ophthalmic evaluation.
Thank you, sir. Can we have this one? Hi, a very good afternoon to all of you. I am Dr. Hinav Kaur Dhillon, and I am a senior resident here at GMCH. Today we will talk about basic evaluation of a neuro-ophthalmological case. So there are a few terms that I'd like to get clear because we use them very frequently. A scotoma, which means that there is a partial loss of vision or a blind spot in an otherwise normal visual field. A homonymous defect, these are bilateral visual field defects that happen on the same side of the visual space in each eye. So it's either on the left side or on the right side. Then we have heterogeneous defects, which are bilateral visual field defects on the opposite side of the visual field. And what is hemianopia? That is loss of sight in half of the visual field. So these are few terms which we'll be using very commonly. So what is the aim of a neuro-ophthalmological workup? The aim is twofold. The first aim is to localize the lesion. That is, where is the lesion? Is it in the retina, in the optic nerve, in the optic chiasma, tract, lateral geniculate body, the radiation, or the cortex? And to suspect the pathology. What is causing this lesion? So we go by the mnemonic of Wind, Ditch, and Deep. So is it a vascular lesion, infectious, neoplastic, traumatic, demyelinating, inflammatory, congenital? Is it a familial condition? Is it a metabolic disorder, or is it drug-induced? The examination starts as soon as the patient enters into your clinic. We start to notice the gait because we need to see if it's an ataxic gait that's most common in cerebellar conditions or in sensory conditions, or if it's a short step gait which is common in patients with Parkinson. Circumduction, which is commonly seen in patients who have upper motor neuron lesions, and waddling gaits, they're seen in myopathies. Facial features can also offer clues to various neuro-ophthalmological diagnoses, such as an abnormal head posture that signifies some nerve palsy, or some ptosis, or a drooping of mouth, or dribbling of saliva, which are common in some nerve palsies. From the build, if a build of a patient is cachexic, we can suspect tuberculosis. Tuberculosis, as we all know, has a lot of neuro-ophthalmological manifestations. Skin, we have neurofibromatosis or other phakomatosis. We have a lot of signs in the skin, as we see. Or pointers from clothing and mannerisms can be taken. For example, patients with dementia or frontal lobe disorders often have characteristic clothing mechanisms. We should devote at least 10 to 15 minutes for a detailed history-taking and examination in neuro-ophthalmic patient. Half of a diagnosis can be made in such patients by taking meticulous history. It is essential to record the age, as a lot of disorders are age-specific. For example, we see optic neuritis in, say, younger individuals, or AION or ischemic optic neuropathies in slightly older individuals, or giant cell arteritis in even older individuals. Gender is also very important because there are certain diseases that have predilection for females, such as multiple sclerosis or optic neuritis. Occupation is also important. So we need to ask the patient his chief complaint, and we grossly say this: tell me what your problem is in one sentence. So that gives us a cue as to which direction we need to move forward in. We need to document the onset, the severity, side progression, and the associated features of the visual symptoms. Usually patients coming to us in tertiary centers have been to a lot of other primary ophthalmologists, so we should always see their discharge summaries and details, any of their old neuroimaging records that they have. So differential neuro-ophthalmologic entities related to history: decreased vision. We need to ask whether it's a transient visual loss or is it a visual loss that has lasted greater than 24 hours. Transient visual loss, again, we can ask them if the recovery was within seconds or within minutes. That's also going to give us a clue as to what the pathology can be. Loss of color vision: is there hemifield loss or is there side vision loss? Loss of contrast sensitivity: patients often complain that colors appear faded to them. Is there any nystagmus? Because in people who have acquired nystagmus, they are often going to complain of oscillopsia, that is also rocking of the world, like things around them are also going to rock. If there is any eye or orbital pain. ये आपका नहीं है सर, मेरा है. If there is any associated headache, especially if there are migrainous headaches or they are usually associated with aura. If there is any double vision, and it's essential to ask the nature of double vision, whether it is intermittent, constant, that gives us a clue to what the pathology may be. Squint, recent onset, if it's present since childhood, these are the questions that we need to ask. Other associated lid symptoms such as ptosis, lid retraction, or ordinal signs such as proptosis. Loss of vision is essential to ask whether it's unilateral, bilateral, is it sudden and serious. Smaller children, parents usually come with complaints of that the child is not fixating on the face of the mother, or they don't follow toys. In such cases, we usually ask for any squint or any nystagmus, whether this visual loss is progressive, non-progressive. And if it is a transient visual loss, how much is the recovery rate? Is it 100% recovery? Are they not recovering complete this thing? And also, what is very important is time until recovery in transient visual loss cases. Loss of sight vision usually presents, patients usually come with complaints of that I often bump into objects, or the child often bumps into objects, and I'm unable to see, vehicles just appear from the side while I'm driving. So there are a few visual field defects that we need to keep in mind. For example, the outer field defects, they usually signify some temporal hemianopia, which can be a part of a bitemporal hemianopia or an ipsilateral homonymous hemianopia. These again are conditions that would point out towards a lesion happening in the brain that is compressing our optic tract or optic chiasma. Then again, in the inner field, we may have some nasal hemianopias that may be a part of a contralateral homonymous hemianopia. Or we may have inferior half scotomas, which are usually suggestive of some ischemic pathology. Central loss of vision with difficulty in reading but no ambulatory problems, because these are central scotomas which are very small. They may be seen in drug toxicities. Loss of color vision and contrast sensitivity: usually patients complain, they say that they have difficulty in matching colors, or the colors appear very faded to them. So we should, when we examine them, I'm going to come to the examination part soon, we should especially check them with red filter. Headache, we need to ask whether it's associated with vomiting, seizure, because they may indicate some pathologies like idiopathic intracranial hypertension, which may lead to papilledema or something like that, or postural changes. Then again, they're suggestive of vertebrobasilar insufficiency. The duration of the headache, the location of the headache, the nature, whether it's associated with aura or not, because they're very typical of migraines. The radiation and laterality, severity, any aggravating or relieving factors. Another very important symptom that we need to inquire about is the double vision. We need to ask whether it's binocular, monocular. I think by now we all know that if you occlude one eye and if it's still persisting, the double vision, it is monocular double vision. We usually have an ocular cause for it. And if with both eyes open, there is double vision, it's a binocular double vision, we probably have another cause to it other than an ocular cause. And we also need to ask whether it's constant or intermittent, because constant double vision is mostly in favor of some nerve palsy or some supranuclear ocular motility disorder. Intermittent double vision can be due to myasthenia, thyroid ophthalmopathy, or we need to ask for progression, and we need to ask for type of separation, whether it's a vertical diplopia or a horizontal diplopia or a torsional diplopia. As we can see in the picture above, it's a torsional diplopia. The one with the book and the glasses is a vertical sort of diplopia, and the one with the bottle is a horizontal diplopia. We also need to inquire about any squint or nystagmus, or we need to see about when the patient is just sitting in our exam room, we need to check for any squint, nystagmus. Need to ask for laterality. If it's a child or age of onset, we need to see. If the age of onset is not certain, we usually ask parents to get in some old photographs, like to review old photographs. Family history of squint is important. Frequency and duration since which the squint or nystagmus is occurring is also important. Any abnormal head posture the child is or the patient is adopting during the examination. History of prior glasses, amblyopia therapy, patching. For nystagmus, oscillopsia is a very important question because acquired nystagmus usually is associated with oscillopsia. Pupil size should be noted. Usually it is noted by a family member. Always remember to check old photos because patients, you need to know since when the anisocoria is occurring. Patients may complain of symptoms in near work, or they may have symptoms such as photophobia. Always rule out any history of previous herpes zoster, trauma, surgery, as they may also be causes for anisocoria. Ptosis, the parents or the patient often complains that the eye has become smaller in size. It's actually the lid that has started to droop. We need to inquire about the onset of ptosis, progression, whether it's associated with any dyskinesis or dysphagia or jaw weakening phenomena or a generalized muscle weakness. Because if there are systemic signs as well, they may go in favor of, say, myasthenia or chronic progressive external ophthalmoplegia or other generalized myopathies. Always review old photos, ask for diplopia. So this is a video of a boy who has Marcus Cut jaw weakening phenomena. As you can see, he's moving his jaw, so we have synkinetic eyelid. Always look for other lid signs. There's lid retraction if there's inability to close the eyes, or there's twitching of lids. Twitching of lids may be seen in hemifacial spasm or blepharospasm. Inability to close the eyes, commonly seen in seventh nerve palsies. Ask for proptosis, onset, progression. If it's sudden onset proptosis, we may suspect some vascular etiologies or some infective etiologies. If there is associated pain, again we suspect infective or vascular etiologies. If it increases with postural changes, especially Valsalva, etc., again we suspect vascular malformations or ileal malformations. If there's associated redness, corkscrew vessels, etc. Always ask for old images to see if this is something which is of recent onset or which has been there and has been increasing. Neuroimaging and visual fields are often very helpful. Systemic history is an important part of neuroophthalmic history. Always ask for diabetes because we have a lot of diseases associated with it, like ischemic optic neuropathies, diabetic papillopathy, consecutive optic atrophies, a lot of nerve palsy, especially the third nerve palsy, or orbital cellulitis. Hypertension is again an important history, especially for hypertensive patients. Need to ask about a night dose of antihypertensives because nocturnal hypertension is a risk factor for ischemic optic neuropathy. Carotid and ischemic heart diseases, it's also important to ask about them. They are again related to ischemic optic neuropathies or ocular ischemic syndrome. Head injury, trauma and loss of consciousness is important to rule out, especially in road traffic accidents or in cases of assault, to rule out traumatic optic neuropathy and associated cranial nerve palsies. Tuberculosis, because of the disease you may have optic neuropathy. Second, because of the treatment that you get for the disease, you may have ethambutol toxicity. Giant cell arthritis again presents with visual loss, diplopia, headache, jaw claudication, scalp tenderness, so we need to ask about these signs. If there's a primary tumor in the body, especially if we have an intracranial tumor, they present with characteristic visual field losses. Thyroid disease also important to ask because they present with proptosis, thyroid-related optic neuropathy, or they may also have diplopia. So we need to inquire into those. After this medical history taken, we should always look into systemic neurological history, family history, because we have a lot of optic nerve disorders which run in the family, for example, dominant optic atrophy or a few of the mitochondrial optic nerve disorders. Social history we need to ask because we have toxic optic neuropathies related to smoking or ingestion of betel nut, etc. Coming to the examination part, we have a basic examination and special examination. Basic examination will cover vision, color vision, visual field testing, ocular motility, pupillary evaluation, slit lamp examination and fundus examination. Coming to the special examination, we have cranial nerve evaluation, neurological and systemic evaluation, ocular and neuroimaging, which includes CT, MRI, MRV, and electrodiagnostic tests. Examination of vision is essential to record the uncorrected and best corrected visual acuity both for distance and near. We can use a regular Snellen's chart or an EPDRS chart for adults, and for children we have various charts. We can use an Allen's preschool chart, or we have Lea symbol charts. For very small children we can check for the follow and fixate behavior, or we can check for the CSM vision. In cases where we have unexplained reduced Snellen's visual acuity, always do a four-prism base out diopter test to rule out microtropia. Always rule out latent nystagmus. In infants, we can also, very small infants, we can use an optokinetic drum. And cycloplegic refraction is a must for all children who present with esotropias. So we have, I have a few examples. This is a child which is actually fixing and following the toys, as we can see. So we can check the fixate follow behavior as such in younger children. Whereas, on the other hand, we have this child who is not fixing and following. He is not interested in looking at the object. Then we need to check for the test of suppression. This is the sensory testing. Ideally, it should be done before we break the fusion of both the eyes. So the most common test is the word dot test. I'm sure everybody knows about this, so not going into detail. Then we have the four-prism base-out test to check for foveal suppression, and we have the stereo acuity, which can be done both for distance and near. We commonly perform it for near, but in patients where we have intermittent squints, we should perform it for distance as well. So we have a lot of these tests. We have a Titmus-Fly test, TNO test, or Randot stereogram test, which use Polaroid glasses, and we have other tests like Lang and Frisbee test, which do not require the use of Polaroid glasses. Color vision, we have pseudo-isochromatic plate tests such as the Sciarra test and Hardy-Rand-Rittler test. Otherwise, we have Langton test, and the hue tests are the most sensitive tests. The 100 hue test is the most sensitive test, but it's very cumbersome, so we can use a D15 test instead, which gives us very similar results to 100 hue test. So as a rule, Kollner's rule it is known as, the outer retinal diseases and media changes usually produce blue-yellow defects, whereas diseases of the inner retina, optic nerve and the visual pathway, they usually produce red-green defects. The only exceptions to the Kollner's rule are chronic papilledema and glaucoma, which produce yellow defects, blue-yellow defects, and a retinal disease that is Stargardt's disease, which produces a red-green defect. Coming to visual field testing, it can be done either by confrontation or we can perform automated visual fields. So by confrontation, each eye is tested separately. The patient fixes on the examiner's nose. The patient and the examiner are sitting face to face, 50 centimeters apart. Usually the knees are touching, that produces almost that much distance. And we are, each quadrant is tested separately. I'm going to show you a small video of how gross visual field assessment is done during confrontation tests. So we first check for spatial neglect. So we show fingers and ask them to see.
Now the opposite. Can you see anything in my hand? number 2, 5, 1, 2.
Okay, so this is how we check in all quadrants.
Where the pen appears, say yes. When the pen appears and disappears, say no. And when you cannot see the pen, say no. Can you see the pen? Yes. 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 Yes.
Okay, so it's okay. कोई बात नहीं, ये वीडियो खत्म हो गया. And then the test is repeated for the other eye as well. It's important to localize where the visual, because visual field localization that gives us a cue to where the disease may be. For example, optic nerve disorders usually produce monocular.
I think you can skip this. I'll be covering this in my talk.
Sure.
You can just skip, yeah.
We need to come to ocular alignment. We need to see any abnormal head posture, which is usually taken up by the patient to maintain a binocular single vision. We can do a patch test to differentiate between ocular cause or a musculoskeletal cause. If the head tilt or the AHP is still persisting after patching, it's most likely a skeletal cause. If it is not there, if it disappears after patching, it is most likely an ocular cause. We usually do ocular cover tests and alternate prism cover tests to measure the deviation. Right, in very small children, uncooperative patients, we may have a light reflex test such as Bruckner's or Krimsky, modified Krimsky test, and prism undercover test may be done for dissociated vertical deviations. It's often essential to check for ocular motility because a lot of neuro-ophthalmological patients may have cranial nerve palsies. We check for ductions and versions, and ductions may be better than versions in patients who have innervational problems. We record the restriction or the limitation of motility by using the Kassenbaum's Limbus test of motility. We also like to check for smooth pursuits in saccades. Saccades are usually the slowdown in internuclear ophthalmoplegia or in CPEO, myasthenia, and supranuclear eye movement disorders or other systemic neurological disorders like Huntington's disease or cerebral degeneration. In very small children where we are unable to check for ductions and versions, we may check for the movements by doll's eye movements. How to check for saccades and pursuits? We sit across, we have two targets and we ask the patient to quickly fixate between the two targets. If there is any slowing of if there's a lag in the movement between the two targets, we usually suspect slowing down of saccades, which may happen in the conditions I just enumerated. Or we may ask the patient to follow a moving target. In patients complaining with complaints of diplopia, it's always essential to perform a diplopia charting. We usually use red-green goggles and we show vertical linear light source at 1 meter distance. The light should be kept upright and should be moved in each position of these, and it should be visible to both eyes and it should not be obscured by the patient's nose. And we question the patient about diplopia in each case. The important points to notice are whether there is horizontal or vertical separation between the objects, whether there is torsional element or not, where is the separation of images maximum, in which ways it is maximum. So we need to document it in such a way. I have a few examples here, and this is how we can arrive to a provisional diagnosis. In case the patient does complain of a torsional diplopia, it is usually advised that we do a double Maddox rod test to measure the degree of torsion. Then another important test that we do is a passive force structure test. Here we are holding the eyeball and the limbus with two forceps. We ask the patient to, this is all done under topical anesthesia. We need to explain the procedure to the patient beforehand. And we hold the conjunctiva and the limbus because that is the place where the tenones and the conjunctiva are firmly adherent. And we move the eye. If the eye is passively, if we are able to move it fully in all directions, that means the movements are mostly free and full. If there is if we feel a tug, there is a restriction of movements and we need to document it. A tug of a movement may be felt in some restrictive cases or in cases where there is entrapment of muscles post-fractures or in some congenital anomalies such as Duane's or where we may have tight muscles. Pupillary examination again is very, very essential. Pupillary reflexes are active in a child above 6 months of age. Briskness and sustenance of the pupillary reaction should be looked for. We should document if we have ill-sustained pupillary reactions. Direct and consensual pupillary reactions should be checked. We checked it by swinging flashlight test. We can also grade the RAPD by this test. Either it can be done clinically or we can grade it by using neutral density filters. We should always look for light near dissociation. And pupil gaze synkinesis, we should also look for signs of aberrant regeneration of third nerve. Again, pupil gaze synkinesis is such a sign. Then we go in for slit lamp examination. We do have some characteristic features in some neuro-ophthalmological diseases which can be seen on the slit lamp. For example, leash nodules in neurofibromatosis 1, or we may have posterior subcapsular cataracts and NF2. KFA may be seen in Wilson's disease, and conjunctival telangiectasias or Cox-2 vessels may be seen in cases of AV orbital malformations. Exposure keratopathy, optic neurotropic keratopathy may be seen in 7th nerve palsies. Fundus examination is an essential part. We need to specially evaluate the optic nerve head. We see them under the following headings: the size, we need to look for any hypoplasia or megalopapilla, or we need to look at shape of the disc, whether it's a tilted disc, the color that gives clue to whether it is hyperemic or whether there is atrophy or pallor, margins, whether they are well defined or is there edema, and the RNFL, we check the RNFL by using a red-free filter. Always look at the retinal vessels in the background because we also need to see if there is any associated, say if we have optic neuritis, if there is any associated neuroretinitis or something like that. And then we come to the macula in the end because we may have conditions like optic nerve head pit may have macular edema, etc. with it. These are a few examples as we can see. So we see some disc hemorrhages nearby. We also see some pallid disc edema. So they probably could be a case of AION. This is a case where we have buried optic nerve head drusense, and we also have some surface drusense here as well.
I think you should sum up now. I mean, we can't teach the whole neuro-ophthalmology because it covers strabismus, it covers retina as well, yes, it covers neurology as well. So just kindly sum up.
Okay, so we need to go in for a special examination as well if we have all of these features. Training nerve evaluation is important. Second, third, fourth, fifth, sixth, these we have covered. Eighth nerve is important to look at because we need to rule out features of optic acoustic neuromas for NF. Ocular neuroimaging is very important. When to do a CT? When we suspect bony deformities, it's essential to do a CT. For soft tissue disorders, we should order an MRI, and when we suspect vascular disorders, we should go for an MRA or an MRP. Electrodiagnostic tests, ERG and VEP are the main tests that are done. When we are suspecting purely optic nerve disorders, we go in for VEP tests like optic neuritis, optic neuropathies, visual functioning in infants, or for malignant. And when we suspect associated retinal changes, we should go in for an ERG. We should put all the pieces together and document our findings meticulously. Thank you.
Thank you. I mean, that was a wonderful overview about the neuro-ophthalmic examination and evaluation. First one needs to look at what you're suspecting and then go about it. A diplopia case, you'll have to go in one direction. A patient with loss of vision or blurring of vision, you would have to take that course, that what you're looking for. Then you will have to check his visual acuity, whether the patient has RAPD or sluggish pupils. And color vision, very important for those cases which just come with blurring of vision. The duration is very important, how it started, whether it was a sudden loss of vision which could give you a clue to an ischemic event versus a gradual loss of vision, whether there was a return of visual acuity or it remained like that. So all these things have to be put together. And then you have to identify what you need to investigate for. So it's not that difficult. Clinical clues help you a lot in neuro-ophthalmology in guiding you what you would like to investigate for. So it's very important to know the basics for examination of a patient with the blurred vision versus the one who comes with double vision. Probably those are the two things which a neuro-ophthalmologist would encounter and that's how we have to deal with it. Visual fields are very important, which, as she rightly said, confrontation is something which you can do in the clinic, because when your vision is low, you might not be able to do a visual field examination, a Humphrey visual field examination, and there confrontation field is very important. So I'll be just touching upon those fields which can give us a clue. Thank you. Good afternoon, everyone. So as this is a PG teaching program, so I'll be just touching upon the basics of visual field examination, which are very important in neuro-ophthalmology. So why they are important? Now, they are done in patients with glaucoma as well, but in neuro-ophthalmology, what they help is in localizing lesion. And a good, why you should know, you should have a good knowledge about the visual pathway in such cases, because that is how you're going to localize the lesion. Because in field effects, they conform to specific patterns. So any topographic pattern, any topographic lesion would have a specific pattern, and variation in patterns have to be carefully interpreted. Sometimes you have imaging which is negative in your ophthalmology, so these visual field patterns give a clue. You might have optic chiasma information, which is called a chiasmitis. It might not have any enhancement, but a field effect like a bitemporal hemianopia would help you in localizing these lesions. Then you have metabolic lesions which affect the cortex. You have like seizures and cortical atrophy, which can produce homonymous hemianopia without any imaging findings. And many times in lesions of the optic, you can say the optic tract, and in lesions of the lateral geniculate body, probably you might not have imaging that is so clear, but you can have visual field defects that would give you a good clue. So remember that the visual system gets divided vertically at the chiasma and horizontally before that. So if you have something before the chiasma, you would usually have a horizontal defect, but if it's chiasma or beyond, it will obey the vertical immediately. And progressive visual field defects are unlikely due to a neurological cause, as you would see in a glaucomatous cause, if imaging is normal. So just to start off with this, now this is a non-localizing field defect. It is just in one of the eyes, and you can see here it's obeying the vertical meridian. There is a threshold difference between the right and the left side, but it's in the periphery. Okay. No doubt you have to look at the retina for this thing, because you can have a lesion just superior to the optic disc or the macula, which could give you a lesion which is inferior. So first of all, have a look at the eye, have a look at the fundus. That's very important before going in for further investigation. So these are just non-localizing field defects. In neuro-ophthalmology, they are not going to tell you anything except if there is some kind of a structural lesion in the retina. So this is the most important slide. This is very important because this topography is going to tell you where the lesion is. So you have a left and a right visual field, and if you see these fibers here, the temporal fibers here and the nasal fibers here form what is known as the optic nerve. And the nasal fibers will cross at the chiasma. So this is the chiasma. So what is happening is the nasal fibers are crossing here, but the temporal fibers from the other eye are just going straight to the lateral geniculate body. So this is what you have, the tract lesions, the lateral geniculate body lesions here, and you have lesions in the visual cortex area, that's the temporal and the occipital lobe, the temporal and the parietal lobe, which form what you call the optic radiations here. So if you have a lesion here somewhere here, it will give you a visual field defect in just one eye, not in this eye. But if you have a lesion here in the chiasma, it will give you a defect in both the eyes because of the crossing. And because you have beyond the chiasma, what you see here is you have a temporal fiber from one eye and the nasal from the other eye. So again, anything beyond the chiasma would have a visual field defect in both the eyes. So this is very important. So preferential nasal field defect without a hemianopic character like glaucomatous, insidious bilateral central or central cecal defect is the hallmark of intrinsic optic nerve disease, which could be hereditary, which could be nutritional, which could be toxic. And if it's unilateral, always check the temporal field of the other eye to rule out a junctional scotoma. So if you're just having a unilateral temporal field defect, that's very rare. So always examine the other eye for a scotoma. So coming to the specific topographic patterns, the first one is what you have when you have a patient of papilledema. So what you have here is enlargement of the blind spot. So the blind spot is usually what? It's about 15 degrees from the center, that's the fovea. So it's about 15 degrees from the center and about 7 degrees vertically. So you can see here this line is divided between 15 and 30 degrees. So at 15 degrees you will usually have this blind spot, and it's about 7 degrees vertically. So if it's enlarged up or below, that means there is some enlargement of the blind spot, and which can be caused by, as I said, outer photoreceptor lesions. They could produce visual field defects corresponding to the shape of the lesion and have a normal fundus appearance, making the diagnosis difficult. So a history, as said in the previous examination, is very important. If there is a visual field loss, if it was sudden or if it's gradual, was it associated with headache, any transient obscuration of vision, everything is important. So papilledema is the most common cause of all these things. Well, you can have it in optic neuritis, but if you have it in optic neuritis, you will have signs like RAPD. Patient would have pain, they would be, you can say, color vision deficits. You can have these lesions in high myopia as well. So coming to the central or centrocecal defects, so what are they? The central defects. That would be because of, you can see here, a centrocecal defect here, which is, centrocecal means from the center to the blind spot. So that's the centrocecal defect here. So these defects are usually seen, if they are unilateral, they are basically because of, you can say, maculopathy, and if they are bilateral, they could be toxic, they could be hereditary, they could be nutritional. So these defects are usually because of the papillomacular bundle, which is from the fovea to the optic disc. So these are known as central or centrocecal. Centrocecal means going from the center to the blind spot, the optic disc. Then you have a central scotoma, and these, as I said, these are hereditary optic neuropathies. You have a central scotoma here, and you will have, this is the central scotoma here, and this is because of a lesion in the optic nerve of both the eyes. So this is what is known as a central defect in both the eyes, a central scotoma, which is right bang in the center, which is seen in patients, and is bilateral, seen in patients of Leber's hereditary optic neuropathy. Then you can have arcuate, altitudinal, nasal steps and nasal depressions, which are basically, the nasal step is usually seen in patients of glaucoma, but all these defects can be seen in patients with optic neuritis, patient with AION, which is the inferior altitudinal field defect, what we would typically call it, because of the superior fibers which are being affected. So it's you have a defect in the lower portion. So superior fibers are affected, the defect is in the inferior portion. Then you can have patient with papilledema who come with side defect. Then this temporal wedge defect is seen in patients with glaucoma as well as in drusen of the optic nerve head, and this is because of involvement of the nasal fibers. So the nasal fibers gone, the defect is opposite, that's the temporal defect. Then you have bitemporal defects in lesion involving the optic chiasma, as I told you. Why you have that? Because you have the nasal fibers crossing. So if the nasal fibers are crossing, the field of the nasal fibers is temporal. Okay, so you have a bitemporal field defect because this nasal is crossing here, this nasal is crossing here. So the defect is bitemporal, which is shown here. So this is a bitemporal field defect which you will see in lesions involving the optic chiasma. It could be pituitary adenoma, a craniopharyngioma, or hypothalamic tumors. Then you have chiasmitis, as I said, ethambutol toxicity, which is one of the most common reasons of chiasmitis, that's inflammation of the optic chiasma. So optic chiasma means bitemporal heminopia. This is again, look at the grayscale. Sometimes you don't have to look at all the other things, they might be very subtle. But the important point is in neuro-ophthalmology, look at the grayscale, see where it's dense. So this is a bitemporal heminopia which is occurring in patients with chiasmitis, and of course the patient did have optic nerve involvement, so you have a central scotoma as well along with it when the chiasmitis resolves. So the chiasmal inflammation is gone, but the optic neuropathy in both the eyes is still there, so that's why you're having a central scotoma. Then you can have unilateral temporal hemianopia. So unilateral temporal hemianopia will be because of just the nasal fibers here. It's in just in one eye. So when you have this, remember that you have to check the other eye, because sometimes what happens, this nasal loop, what happens, the tumors here go on to the other side as well, because the nasal loop bends here, which is known as the von Willebrand knee. So the nasal fibers bend here before going on to the other side. So if you have a temporal on one side, always check the other eye for a scotoma. That's what you call a junction scotoma. So going on to defects which are behind the chiasma. So at the chiasma, before the chiasma you have unilateral defects. At the chiasma you have a bitemporal field defect. But once you go beyond the chiasma, what happens is you have nasal fibers which have crossed and the temporal fibers which are uncrossed. So you have the field of one eye and the field of other eye. So it's homonymous. So you have a nasal field of one eye and a temporal field of other eye. So any defect here or beyond, that means behind the chiasma or beyond, is going to produce a heminopia. So a complete defect means both the fields, the similar field, you can say the congruous field, the temporal field of one eye and the nasal field of the other eye are gone. That's a complete defect, means it's filling all the area on one side of the vertical meridian. So it's very difficult to localize whether lesion is here, whether lesion is in the radiation, or whether it's in the visual cortex. Then you have a key-shaped defect. I will just show you in the lateral geniculate body. So what is important is the incongruous defect. Now incongruous defect means they are not similar in size and shape. So you have defects here which are, you can see here, similar in size and shape, but there are defects which are not similar in size and shape. So the more interior the defect, you can say, if it's in the optic tract here, as compared to the visual cortex, is going to be incongruous. So if it's interior, it's going to be incongruous. That means it will differ in size and shape. But if it's more posterior, it will be more of a congruous defect. So the lesions could be in the optic tract. You can have a pie in the sky when you have a temporal lobe lesion. Is the pie on the floor when you have a parietal lobe lesion. And as I told you, congruous defects means similar in size and shape, and it identifies that the lesion is very posterior. So that means an occipital lobe lesion. So this is how you can just localize these lesions, knowing the gross picture what you are going to get and where the lesions are. So just to show you, this is an occipital lobe, right eye occipital infarct, and you have a left homonymous heminopia. You can see the grayscale here is almost similar. So it's like a little congruous defect. What you are seeing is it's a heminopia. That means the nasal field of one eye and the temporal field of other eye is gone. So it's more of a occipital lesion because it's a congruous. But remember, field is nothing. Field is just one part of the examination. The rest of the examination also have whether there is a loss of vision, blurred vision, pain, no pain, RAPD, no RAPD. Everything is going to tell you to help you in localizing the lesion. So this is what I told you, this is like the pie in the sky. Okay, so this is a superior quadrantonopia, which is because of inferior visual cortex lesion. That means the lesion is in the temporal lobe. So pie in the sky, which is a superior homonymous quadrantonopia, is because of lesions here, which is the temporal lobe here. And if you have a pie on the floor, that means if you have a lesion here somewhere, in both the quadrants, that is because of a parietal lobe lesion. So remember these things when you are having a quadrantonopia. So coming to some of the other lesions which you have, like a homonymous paracentral scotoma. So you can have a scotoma and you can see the both sides here. You can see here a paracentral. It is just next to the, you can say, the center. So it's same, you can say, on this side and it's on the other side. So it's a homonymous pattern what you are having. So this homonymous pattern tells you that this lesion is very close to fibers which represent the macula. So fibers which represent the macula are in the posterior part of the occipital lobe. That is just at the tip of the occipital lobe. So that's how you identify where the lesion is. You have a paracentral scotoma, homonymous, very close to the, you can say the fibers representing the macular area. Think it's near the occipital tip of the occipital lobe. Then you have what you call a macular sparing homonymous heminopia. So you have a homonymous heminopia, but you can see here the central part here is spare. So again, this lesion is in the interior part of the occipital cortex. So the visual cortex, the interior part does not have macular fibers. The macular fibers are just in the posterior part. So this lesion localizes here because it's a homonymous heminopia. And this is what I was trying to tell you. This is an hourglass pattern. It's like a, you can say the lesions in the lateral geniculate body. Okay, so you have two blood vessels supplying the LGB. Which layers are affected will give you this pattern. This is a very rare thing to have. But just to show you the pattern that I put this picture here. So coming to just ending my talk with these, I mean this is like something what you call a constricted field. Okay, now this constricted field could be because of some other lesions, or maybe how to identify whether it's because of a cortical lesion. That means it's a bilateral homonymous hemianopia. So that you would get in bilateral visual cortex lesion. Because in one side of the visual cortex it will be a homonymous hemianopia, but you're having both sides homonymous hemianopia. So both nasal fields gone, both temporal fields gone. So how you identify is, so basically they should be overlapping. So if you see here, this is overlapping. So you have an overlapping field. This is one of the clues, and the other is a step off in the vertical meridian. So the step off means that this region is corresponding to this region, this part is corresponding to this part. So that's how you identify it. It's just not a constricted field, it's something else what is going on, which could be a bilateral homonymous hemianopia. So the temporal crescent, as I told you, temporal crescent is something which extends beyond what visual field can give you in a Humphrey chart. It's like a 60 to 90 degrees region. Normally a Humphrey would give you 30 degrees. You have 30 degrees, you get 30-2, you get 24-2, so those are 30 degrees. So but for a temporal crescent, it has to go beyond that, which will not be visible on a Humphrey field. So for that you could do a confrontation test, and while a temporal crescent occurs, it's a unilateral crescent, a unilateral scotoma beyond 60 degrees. Okay, so that is because of a region in the occipital cortex where only the temporal visual field is represented with no input from its nasal counterpart. So only one temporal field without a nasal counterpart is what you call a temporal crescent. So basically this is just a summary of the topographic patterns of visual field loss and how you would identify where you are suspecting a lesion. So this is just a table, and which will give you a clue to what's really going on with the visual field defects. So I just want to conclude here by saying that it's a stepwise approach. We need to first determine whether it's a normal or abnormal field. No artifacts, I mean like testing conditions, put the correct refractive correction. If you have ptosis, that could be a cause of a visual field defect, because it will be covering part of the visual field. And then you have to know whether one or both eyes is involved. If it's just a horizontal meridian which is being involved, or it's a vertical meridian being involved, because the horizontal would be before the chiasma, vertical would be chiasma, or behind the chiasma. See the specific areas involved, like I showed you, a quadrantonopia. So you have to be very specific, or just a paracentral scotoma, what you're getting, and see where the greatest amount of loss, where the greatest density is. Check for specific shapes, sizes, patterns, the meridians, whether it's congruous or incongruous, symmetric, asymmetric. But remember, always use this in conjunction with clinical afferent information to narrow down a diagnosis. Visual field is just not one thing. It's all, you can say, a combined approach of good clinical examination and a good visual field examination and interpretation. Thank you. So if you have any questions, I mean, I can answer that. Otherwise, we will close the session. Okay, if there are no questions, then we'll close the session here. Thank you so much.